Doctors, we are live.
Okay. Good evening, seniors, friends, and delegates. It gives me great pleasure to, uh, invite you to the Retina at 25, the journey of 25 years of Retina Institute, our Silver Jubilee celebration, and our 25th CME. So I'll just run through our journey of 25 years in a short time. Footprints in on the sands of time. We initially were both of us, Dr. Muralidhar and myself, started practice in Bangalore in 1990, and we used to interact during our surgeries. And then Dr. Hilton came to Bangalore in 1996, and he encouraged us to form a center of retina, and he called it Retina Institute of Karnataka, which we started as a small outpatient place on 23rd of June 1996. He inaugurated the center, and that's just his plaque. Dr. Badrinath and Dr. K.R. Murthy were the chief guests on the occasion, and we could get their blessings on this occasion. We moved over to our new building on Jan 1999, which is our current building, and we had the senior most ophthalmologist, Dr. Krishnamurthy, inaugurating the premises. These are some pictures at that inauguration, and we also had a beautiful message from Dr. Hilton and his wife on this occasion. We have now all the equipment to provide good quality care to our patients, and we are ably assisted by our team of anesthetists, Dr. P.M. Chandrasekhar, Dr. Iris, and our retina other consultant friends. We also have phaco-refractive surgery department run by Dr. Nagesh. Then we have the glaucoma department and the pediatric ophthalmology department. Incidentally, we had our first CME before we inaugurated our center. This was in April 1996 when Hilton inaugurated the CME, and we had eminent speakers, in that program. We continue to have one CME every year over the past few years, and we have had all eminent speakers. Here you can see Dr. Badrinath in one of our CMEs, Dr. Nagpal. You would probably all have participated in one of the CMEs that we have done so far, Dr. Lingam Gopal. We had the International Symposium of Intraocular Inflammation in 2003, wherein we had Dr. Narsingh Rao coming for that program. We had eminent UVA speakers during the session. These are some pictures from that. We had the International Retina Congress in 2006, wherein we actually honored 6 of our seniors, gurus, as you could call it. You can see Dr. Tiwari, we had Dr. Badrinath, Dr. Nagpal, Dr. Namparmal Swami, Dr. Patnaik, Dr. Tiwari, and Dr. Girgiri Roberts. And we had the fortune of seeking their blessings on this occasion. We were involved in the organization of the My Retina 2010, the VRSI meeting in Mysore. We had some live surgery programs at, I think, 2 or 3 occasions. We have had live surgeries. We also had Orbis coming and conducting a live surgery at our center. We had very, eminent people visiting our place, including Neil Kelly, Dr. Cameron, Dr. Shivalingam. And here you can see Dr. Jerry Shields, who had interacted with us when he came to Bangalore. We have trained about 70 fellows, both in surgical retina and medical retina from the year 2000. And we were very fortunate to interact with most of them yesterday. And it was really gratifying to meet all our ex-fellows. So in this journey, I think you all have played a great role. I think each one of you has participated and contributed to our knowledge and to the knowledge of all the delegates. Thank you.
Thank you, Hemant, for taking us through our journey. It has been a wonderful journey, and we start our scientific session. Today we have two sessions, session 1 and session 2. The whole session is on imaging. Session 1 is sponsored by CIPLA. We are grateful to the sponsors for the support. So CIPLA is sponsoring this session, and I have great pleasure in inviting the chairman, co-chairman and moderator for this session. Dr. Nitin Shetty is the chairman. He does not need any introduction. He is one of the most well-known vitreoretinal surgeons of the country. He initially trained at Shankara Nethralaya and also worked as consultant in Shankara Nethralaya. Then he moved to Bangalore. He has been in Bangalore for a long time with Manipal hospitals. Thank you, Nitin. He will be assisted by Dr. Rajani Bhattu as co-chairman. Dr. Rajani Bhattu is also a well-known vitreoretinal surgeon. She was also trained at Shankara Nethralaya, and she does her practice in Bangalore. In addition to her busy practice, she also pursues her passion of studying the genetic eye diseases, retinal dystrophies, and also stem cell therapy. And moderating the session will be Dr. Chaitra Jaidev, the rising star in our retinal retinal field. She is a consultant at Narayana Nethralaya, but in addition, she is also a very dynamic young lady. She is also the Joint Secretary of All India Ophthalmic Society and Executive Committee member of BRSI, and also she is Associate Editor of Indian Journal of Ophthalmology. So with this team, I'm sure we'll have a wonderful time. I request Dr. Nitin Shetty to take over and start the proceedings.
Thank you, Dr. Murli. At the outset, I'd like to congratulate the entire team at RIK for this wonderful journey. And it's a sort of a role model for a lot of people aspiring to get into this kind of practice. They've trained a whole lot of people, and I personally have been in many of their sessions. It's always a good learning experience. And I'm sure these sessions are also going to be the same in that time. With this, we can go on to the first talk. This session is on imaging, and we will be first starting the session with the talk by Dr. Manjula. She'll be speaking on clinical application of autofluorescence in retinal diseases. Dr. Manjula is a consultant medical retina and uvea specialist at RIK. Most of us know her through her talks, which we have seen in many of the meetings. She has done a fellowship and medical retina in RIK and a FICO fellowship of vitreoretina and uvea. Dr. Manjula, can you take over?
Are my slides visible, sir?
Yes.
The slides are visible and you're audible, Manjula.
Yeah, thank you. Good evening. Thank you very much, sir, for the nice introduction. I'll be talking about clinical applications of fundus autofluorescence. Fundus autofluorescence is a non-invasive retinal imaging modality which we use in our practice. It is based on a density map of lipofuscin, the predominant ocular fluorophore present in the retinal pigment epithelium. It's become an essential tool for evaluating age-related macular dystrophies, macular degeneration, macular dystrophies, white dot syndromes, retinal drug toxicities, and various other retinal disorders. It has an advantage over picking up certain features which might not be picked up either by clinical examination or even the conventional fundus fluorescein angiography. Hence, it forms a role in elucidating the disease pathogenesis, forming genotype-phenotype correlations, diagnose and monitor disease, and evaluate novel therapies. Before going into detail, let us go through briefly about the principle on which it works. So to produce autofluorescence, fluorophore absorbs a photon of excitation wavelength This causes an electron to be elevated to an excited high energy state, and this electron dissipates some energy and emits a quantum of light at a lower energy and longer wavelength. In this graph, if you see, this is comparing the different wavelength spectrum of different molecules like fluorescein, ICGA, and lipofuscin. If you see lipofuscin, it has an excitation spectrum in the blue area and emission at yellow-green. So most predominantly FAF uses blue light excitation. Emission happens within a preset spectrum, which produces a brightness map reflecting the distribution of lipofuscin. However, it can use other excitation wavelengths also to detect additional fluorophores. For example, melanin, which is detected by near-infrared autofluorescence. So the lipofuscin is the predominant macular fluorophore. As I've already told you, the excitation is at blue range and emission in the yellow-green light. The other fluorophores are A2E, which is a metabolic product of photoreceptors. It is a pyridium bisretinoid with an excitation at 430 nanometers and emission at 560 to 575 nanometers. The other fluorophores are melanin and rhodopsin. And when present, vitelliform lesions and optic disc drusen can also produce autofluorescence. This is a comparison of two kinds of autofluorescence. On the left is the short wavelength, as I've explained you, which uses blue light. And on the right side is the near infrared autofluorescence, which uses melanin. Both are almost similar in terms of disc and the vessels. However, the macula in the short wavelength autofluorescence appears hypoautofluorescent because of the presence of pigments lutein and zeaxanthin, whereas in near infrared autofluorescence, it appears hyper because of excitation of melanin. So coming to abnormal autofluorescence, it can be broadly divided into hyper and hypoautofluorescence. Hyperautofluorescence can be produced either because of increased RPE lipofuscin or presence of subretinal autofluorescent material. A window defect can also produce hyperautofluorescence, or if present, disc drusen can also present hyperautofluorescence. Hypoautofluorescence is caused by either reduced or absent RPE or any material which is anterior to the RPE causing blockage. So covering all the diseases, FAF in all the diseases is beyond the scope of this presentation. However, I limit my utility of FAF in AMD, macular dystrophies, white spot syndromes, drug toxicities, and if time permits, I'll deal very few retinal diseases. Geographic atrophy, as you know, hallmark of advanced non-neovascular AMD, and on FAF, it appears as hypoautofluorescent lesions with sharply demarcated borders, as you see in this picture. There's one more thing you should note is the perilesional hyperautofluorescence as shown here, because this represents area of ongoing RPE cell dysfunction, which may eventually die and cause atrophy. There are varieties of perilesional hyperautofluorescence which can be seen. However, it is presumed that diffuse and the banded variety have the worst prognosis. I have put a picture here of an 82-year-old gentleman. We have his monitoring every year. If you see between the 2018 and the 2020, the lesion, that hypoautofluorescent lesion corresponding to the atrophy is similar, and the perilesional hyperautofluorescence also is minimal in terms of focal. Hence, FAF in geographic atrophy, it helps us to diagnose, prognosticate, and also to monitor this disease as this is known to progress. Next is the RPE tail, which is a well-known complication of wet AMD. It can happen even in the natural course of the disease or with treatment also. It can be best picked up on FAF than on clinical examination, where it appears as a central, well-defined area of hypoautofluorescence because of the absent RPE, with an adjacent irregular hyperautofluorescence because of the retracted edges. However, with time, this shows a kind of remodeling and resurfacing, thereby regaining some of the autofluorescence which is lost. Moving on to the next topic, this is macular dystrophies. In that, Stargardt's is an autosomal recessive condition caused by the mutation in ABCA4 gene, which causes defective outer segment degradation, leading to lipofuscin accumulation with eventual RPE and photoreceptor layer atrophy. In FAF can be used to characterize the phenotype of Stargardt. See, if you see this picture here in the clinical fundus photo shows a beaten bronze appearance in the macula. The corresponding FAF shows a mottled hypo and hyperautofluorescence with a perilesional hyperautofluorescence with minimal amount of flex. This typically corresponds to Stargardt's. When you see the other picture here, here also there is, in the macular area, there is a variable amount of atrophy corresponding to a predominantly hypoautofluorescence in the center. However, what you see extra is the hyperautofluorescent flecks in the periphery with typical peripapillary sparing. This is very typical or distinctive feature of Stargardt's fundus flavimaculatus. Hence, in Stargardt's, FAF not only helps in phenotypic characterization, but it also shows areas of early atrophy and flecks, which we might not have seen on fundus photography, suggesting its utility in detecting early disease. Also, it correlates well with visual function. The normal macular autofluorescence corresponds to good vision. Moving on to the next dystrophy, that's a BEST dystrophy. It's an autosomal dominant condition where there is a mutation in BEST1 gene, which leads to shed photoreceptor debris and lipofuscin accumulation, which produces yolk-like lesions in the macula. There are 5 stages which are best picked up on autofluorescence, which correspond to OCT scans also have put. See, in the pre-vitelliform stage, the short wavelength autofluorescence or the OCT don't show any change. However, if you see the near infrared autofluorescence, you see there's a central hypoautofluorescent lesion corresponding to the pre-vitelliform stage. This can be done best for screening people with a history of BEST disease as it is autosomal dominant. In the vitelliform stage, in the autofluorescence, it is seen as a well-defined homogeneous hyperautofluorescent lesion. The inside that yellow marks the presence of punctum of the lesion. In the pseudohypopion stage, the hyperautofluorescence now collects inferiorly, predominantly seen in the inferior part of the lesion. In the vitelleruptive phase, the hyperautofluorescence now is marked in the periphery. With the center, you see hypoautofluorescence. And when it progresses to the atrophic stage, there is no hyperautofluorescence seen. It is predominantly by the hypoautofluorescent atrophic lesion seen. So in BEST disease, FAF characterizes the phenotype very well, and staging can also be done accurately, but with the help of multimodal imaging. This is an example of a patient with fundus photography showing bilateral yolk-like lesions, which correspond to a well-defined homogeneous hyperautofluorescent lesion on FAF, corresponding to vitelliform stage. In pattern dystrophies also, FAF helps us to typically phenotype the type of the pattern we are dealing. As in AOFPD, it is seen as a focal hyperautofluorescent lesion, which corresponds to a hypopigmented lesion seen clinically. And in butterfly-shaped pattern dystrophy, you can appreciate the wings very well on FAF, which appear as hyperautofluorescent. And in multifocal pattern dystrophy, the flecks are seen as hyperautofluorescent in the posterior pole. So thus in pattern dystrophy also, the usage of FA is predominantly to phenotype characterization. Moving on to the next class of diseases, the white spot syndrome, I'll just give you an example. A 30-year-old lady came with sudden onset of scotoma and flashes. Her vision was 6/6. But if you see clinically, the disc appears slightly hyperemic. The fovea is slightly granular. There are subtle lesions seen temporal to the fovea. But when you see the FAF, it shows numerous multifocal hyperautofluorescent lesions than seen clinically. Or if you do FA, you see more lesions on FAF than FA. So in mutes, this carries a very high sensitivity, greater ease of use, and being non-invasive in nature, it is very helpful first to diagnose and then definitely monitor, because it's a self-limiting disease. The spots eventually fade away. Though serpiginous choroiditis is a clinical entity where diagnosis is based on clinically, FAF helps in monitoring the response to treatment. As you see in the upper part where I have underlined, they show hyperautofluorescent lesions which correspond to active lesions on fundus photography. Which the down one is after the treatment, you see they become more hypoautofluorescent, which is like healing. As you see, the correlation with fundus photo shows that the lesions are healing. That's why they're becoming more hypoautofluorescent. Hence in serpiginous and even in multifocal choroiditis, FAF very much helpful in monitoring the disease. Coming to drug toxicities, the most commonly used anti-inflammatory agent is HCQ, and we know that it is inexpensive, nicely used, liberally used by the rheumatologists. But one thing you have to keep in mind that the risk of ocular toxicity rises sharply with cumulative dose, especially with doses over 1,000 grams. And there is a difference between how
Dr. Manjula, you have 1 minute, Dr. Manjula.
Yes, ma'am. Thank you. Caucasians, it involves the parafoveal region where it causes hyper and hypoautofluorescence, whereas in Asians, it tends to show near the arcades, it tends to show the affection causing the photoreceptor cell loss. So, screening guidelines for HCQ toxicity recommends testing with FAF, SDOCT, perimetry, and multifocal ERG. I'll just take 1 minute. This patient was referred for evaluation of papilledema, and she's completely asymptomatic. Vision is 6/6. There are no complaints, and if you do FAF, it shows the optic disc drusen. So this is very important because this avoids unnecessary referral, unnecessary investigations. And in CSCR, it is assumed that the leakage, what you see on FFA, corresponds well to the focal hypoautofluorescence seen on FAF, thus avoiding the need for invasive procedures. To summarize, it provides information on the metabolic state and overall health of the RPE and indirectly the photoreceptor layer. It's an important tool for evaluation of the prognosis and progression of geographic atrophy in AMD and for the phenotypic characterization of retinal dystrophies. It is very critical in the diagnosis and monitoring of whiteout syndromes and drug toxicities. And in the future, it might replace invasive procedures like fluorescein angiography. Thank you. I want to thank my mentors for giving me an opportunity to be there in this great occasion. I want to thank my fellows without whom this was impossible. And I welcome you all as a part of Team RIK. I welcome you all. I request you to participate and support us and make it help us to make it a grand success. Thank you.
Thank you, Manjula, for that excellent overview of FAF. I'm sure, it is at least helped in a little bit better understanding, though I know it's difficult to go into all the details. So 2 quick questions. First one to Dr. Rajani, actually. Ma'am, if in case somebody doesn't have an FAF at their center, any 1 or 2 particular conditions that you would suggest that they send to a center that has FAF that will help us in an early diagnosis or a better diagnosis?
Yeah, absolutely. I think while FAF does help in diagnosis in conditions like Stargardt's, because especially early onset Stargardt's, sometimes it's hard to diagnose, and children go around with varied diagnosis. So for diagnosis, and she's already mentioned that. But I think more importantly, in conditions like retinitis pigmentosa and again in Stargardt's, FAF helps in prognostication, assessing the progression of the disease. So in RP, for example, there is a typical Robson's ring that we see. I guess all of you are aware of it. So I think that's an extremely important point to say that especially for progression. And so yes, so retinal dystrophies, autofluorescence is the way rather than anything else. Yes. Thank
Another
you.
question. Anybody else would like to add? Yes, sir.
Can I ask a question? Rather make a comment. Am I audible?
Yes, sir.
Yeah. Thing is, I just wanted to add certain conditions which can be helped by autofluorescence in the diagnosis. One is, I think all PGs should know that one of the most important diagnostic modalities for azure, for the diagnosis of azure, is fundus autofluorescence. That is number 1. Differentiation between SREM and acquired vital form deposits is also possible by fundus autofluorescence. I think fundus autofluorescence will show hyper autofluorescence with acquired vital form lesion rather than with the SREM. And the third thing is that in RP RIP, many of our fellows, especially the juniors, would make a diagnosis of a choroidal atrophy, areolar choroidal atrophy, for an area where there is no RP in an RP RIP. So RP RIP will be hypoautofluorescent, and the scrolled part of the RP will be hyperautofluorescent. I think these 3 conditions, I think we can add in the usage of autofluorescence.
It is very useful to pick up small RP rips. Sometimes that can be clinically not picked up by OCT also. So it really gives a good impression of the RP rips. Small RP rips can be easily picked up.
Manjula, you used Spectralis for your FAF. Is that the device that you use?
Use TopCon.
TopCon. So, does anybody would like to add their experience with using FAF on optos? Is it still easy to pick up the lesions, difficult to pick up lesions on using optos? I think that the Daytona new model does have wide field. Is there any application for wide field FAF or are there any limitations?
No.
I think Dr. Cyrus has been using Optos for a while, probably Daytona, I'm not sure.
So, but for macular dystrophies, I think for the macular imaging, I think it's better to have a smaller field than wider. I don't know, people should comment about it.
For multifocal choroiditis, we have the Daytona, by the way,
Yes.
for the last 2 months, and I think it's a really wonderful tool. The fundus autofluorescence feature of the Daytona really works very well for multifocal choroiditis, serpiginous choroiditis, all the choroiditis that occurs in the mid-periphery. I think, yes, for detection of any activity, it does help. Yeah.
So mid-peripheral and slightly peripheral lesions, definitely the Daytona FAF is beneficial. I think if our discussion is through, we can go to the next talk.
We have Chaitra, we have both TopCon and Heidelberg. Most of the things we use in TopCon, if we want good image, we go to Heidelberg. We have both the facilities.
Dr. Cyrus was saying something, sir.
Yeah, no, I was just saying that unfortunately, our Optos went kaput some years back, so we really haven't been doing much on this subsequently.
Okay, okay. Thank you, sir.
So shall we move on to the next topic?
Yes, please. I think we're done.
So yeah, I think we are on time. Can I invite Dr. Kavita Rao for her next talk? So Dr. Kavita is a senior, vitreoretinal consultant at RIK, and following her MBBS from MMC and her DNB, she's done a surgical retina fluorescence from RIK. So Dr. Kavita, over to your talk.
Thank you, Dr. Rajini. And good evening, everyone. So biomarkers are features that can identify a pathology or a disease process. And with reference to AMD and DME, paying particular attention to these OCT biomarkers will help us diagnose a disease earlier, determine the severity, predict treatment outcomes, manage patient expectations, and tailor therapy. With improving OCT technology, we have an increasing list of OCT biomarkers in DME, the most important among them being DRIL. DRIL is disorganization of the retinal inner layers, and as the name suggests, the inner layers, which is the ganglion cell layer, the inner plexiform, inner nuclear, and the outer plexiform layers, are disorganized and cannot be distinctly made out on OCT. So the inner layers, they transmit the visual impulses through neurons. So any ischemic insult to these inner layers can affect the bipolar, amacrine, and the horizontal cells and cause suboptimal visual outcome. So DRIL is known to occur with or without a center involving DME. It's usually seen on OCT B scans in the central 1 millimeter retinal zone, and more than 500 microns indicates a worse visual prognosis. DRIL is usually seen in patients with a higher body mass index and longer duration of diabetes, and in patients who have had DME for a longer period, more than 6 months. Here is a patient who has had a central involving DME, and following treatment and resolution of edema, you see that the vision has not really improved, and you can see that there is indistinct inner layers, so this is DRIL, and it helps us to explain this to the patient why the vision is not improved. This is another example, a bilateral center involving DME. One eye has improved in vision and the other eye has not because of the presence of DRIL. The second, the hyperreflective retinal foci. These are lipoproteins and they're usually seen in the inner retinal layers and can migrate to the outer retinal layers. These are distinguished from hard exudates by being smaller in size. They are less than 30 microns and they're less reflective than hard exudates, and they do not have backshadowing. The size and number of these hyperreflective foci can decrease with treatment, and these are the patients who do better with corticosteroid implants than anti-VEGF. But in spite of corticosteroid implant, these patients also have an early recurrence of DME, so they have to be followed up meticulously. And if the hyperreflective foci are arranged in an order along the cyst, this is called the pearl necklace sign, and this is a precursor for hard exudates once the edema resolves. And if this happens to be subfoveal, then it's a biomarker for a poor visual response. And when we see this hyperreflective foci in the choroid, that means it has migrated from the retina to the choroid. That means that the ELM and the EZ, that is the ellipsoid zone, have breached, which itself indicates that the visual acuity will be poor. So when we see retinal cysts, these are because of the elevated VEGF levels and breakdown of the inner blood retinal barrier, and which cause the cyst formation. So apart from the presence of cyst, we have to look at the size, the location of the cyst, the lateral extension, and associated RPE and photoreceptor damage, and SRF. They have been classified as large, giant cysts, small, large, and giant cysts. Now you see an example here. You have a patient who have a center involving DME, and you see this large cyst in the reaching up to the outer nuclear layer. And following treatment and resolution of the edema, the vision does not improve. That is because of the stretching of the photoreceptors, which causes damage and poor visual recovery. Bridging retinal processes, these are tissues that connect the inner and the outer retina, and these are supposed to be residual neural elements which help in transmitting visual impulses. And if these happen to be in the center of the fovea, they indicate a better visual prognosis following treatment as compared to cysts which do not have them. And fluid under the fovea can decrease vision by various ways. One is diffraction of light, it's misalignment of Mueller cells, or tissue hypoxia, or stretching of photoreceptors. So it's good to quantify the amount of fluid under the fovea, which is by the retinal fluid index, and central macular RFI demonstrates a negative correlation with vision. Good baseline choroidal thickness denotes an intact choriocapillaris and less ischemic outer retina. So that definitely has a better anatomical and functional response to anti-VEGF therapy. Opsin is a major, plays a major part in the visual cycle, and the outer retinal layers are major reservoirs of opsin and ATP. So the PROS length and health correlates better with visual acuity. So here is a patient who has a good outer retinal layers and a good photoreceptor layer, and certainly the visual acuity will be better following treatment. The subfoveal neurosensory detachment, a protective role has been described with the presence of an SRF, and this is associated with good anatomical and functional gains. Integrity of the ELM and EZ, because ELM is composed of Mueller cells and EZ has the inner components of the photoreceptors. So it goes without saying that intact ELM and EZ has a better visual prognosis than when it is disrupted. And disruption could be partial, complete, or continuous. When there is associated vitreoretinal interface abnormalities like a taut hyaloid phase or a vitreomacular traction, this prevents complete resolution of macular edema even with treatment. And central subfield thickness, which is because of intra or subretinal fluid, and the cube average thickness, both of them cause increased EZ disruption and affects the final visual outcome. And hard exudates, this is associated with the biomarker of the systemic biomarker of elevated serum lipids and triglyceride levels. And intravitreal steroids are much better when more hard exudates are present. But if it is subfoveal, it indicates a poor outcome, even with treatment. So in AMD, the biomarkers are very helpful for us in determining and prognosticating the progression of intermediate to advanced AMD, which is either geographic atrophy or neovascular AMD. And as with DME, the list of biomarkers is steadily increasing with the advancing OCT technology. The first and important thing being SHREM, which is subretinal hyperreflective material. This is a OCT morphological feature in which there is hyperreflective material which is located external to the retina and internal to the RPE. And this is usually composed of either fluid, fibrin, blood, scar, or a CNVM. SHREM can affect vision by two ways. One, it can cause a mechanical barrier to nutrient and metabolite exchange, or it can have a direct toxic effect and damage the EZ and the photoreceptor layer. So apart from the presence of SHREM, we need to look at whether there's a layered appearance, increased reflectivity, larger size, or hyperreflective spots, all of which indicate a poor prognosis. And as we have discussed, the integrity of the ellipsoid and ELM is also important. A decrease in the EZ intensity indicates that there's a reduction in the functional mitochondria and causes abnormal photoreceptor function. Some of these features are seen in the genotypes of ARMS2 genotype. So maybe with a simple OCT scan, we are picking up some of these people, and it could be a surrogate marker of retinal function. Intraretinal cysts, these are a very strong prognostic parameter in AMD for the final visual outcome. And we have to be very careful in distinguishing between exudative intraretinal fluid and degenerative intraretinal fluid. The exudative ones are larger, they are circular, ovoid, they are responsive to anti-VEGF, and they need proactive treatment. Whereas degenerative IRC, these are small, they are sharply demarcated, and they overlie dysfunctional RPE. These are passive accumulations of fluid and do not respond to anti-VEGF and do not improve in vision. So by diagnosing this, you can avoid unnecessary treatment. So it's important to treat and detect and treat CNVM early before the intraretinal fluid develops, because watchful waiting may lead to irreversible damage. Subretinal fluid, this is seen in all types of lesions, but typically it's the first exudative sign in type 1 lesions, and they have very good visual benefits through anti-VEGF therapy. And the presence of SRF would indicate that it's a functional perfused vascular network. So the survival factor is better for RPE and photoreceptors. And presence of SRF without an IRF would mean that it's a less aggressive and a supportive stage of CNVM. And usually SRF is not co-localized with IRC or PED. So just the presence of SRF under the fovea would mean that the membrane itself could be extrafoveal and the visual prognosis would be better. So these are the patients in which SRF is present, and without IRF, this could be a benign disease. And these have generally good functional and anatomical response to anti-VEGF. And these are the candidates which probably are good for the treat and extend regimen. So eyes with SRF see better than eyes with IRF. So drusenoid PEDs, they're larger, 350 microns. They have a prognosis. They progress to advanced AMD within 5 years. And fibrovascular PED, these have worse visual outcomes and also resistance to therapy. And very large PEDs with a height of more than 600 or a diameter of more than 5 mm have a risk of RPE rip and poor prognosis. The height of drusen is important. If the drusen height is more than 122 microns, probably the risk of progression to neovascular AMD is higher. The area of distribution is important, and the volume. If the soft drusen become confluent and the volume increases, there's a 4-fold increase in the risk of progression to neovascular AMD. And ERIS has shown us that 82% of eyes who had drusen regression developed geographic atrophy. And the others are the OCT reflective drusen substructures as well as the subretinal drusenoid deposits. Both have a 3-year progression risk to geographic atrophy. Reticular pseudodrusen, these are usually seen superior to the macula, and they have a 2 to 6-fold higher risk of progression to advanced AMD. So hyperreflective pyramidal structures, these are also called the ghost drusen. This is seen in GA and composed of lipofuscin. And this was previously called the subclinical CNVM. It's now renamed as a shallow irregular RPE elevation of the sire. So this is a patient who has a shallow irregular RPE elevation, but there is no intraretinal fluid or subretinal fluid, but the octa can show the membrane. So these are the patients who do not need treatment, but who need very close observation and monitoring, because the exudative shift at both 12 and 24 months is significantly high. Outer retinal tubulation, this is a protective gliotic response, which is usually futile of the ELM, which dips down and encircles the photoreceptors, which are getting destroyed. So this is seen in the outer retina as a cavity, but it has a hyperreflective margin around it as compared to the intraretinal cysts, which do not have it. And this is in the outer retina. This could be in the inner retina also. Hyperreflective foci in AMD, these are dot-shaped intraretinal lesions seen usually at the apex of the drusen and typically correspond to focal pigmentary abnormalities, and there's a 5-fold increased risk of progression to geographic atrophy at 2 years. And the other features that have been described are the nascent geographic atrophy, the RPE and the outer retinal atrophy, or the outer retinal atrophy alone. And these have both complete and incomplete varieties. And the features of this are there is a hyper signal transmission into the choroid, and there is disruption of the RPE, and there is photoreceptor degeneration along with it. So in conclusion, the high resolution and 3D OCTs have just thrown the doors wide open for a bright future for biomarkers. And we should look not just at the thickness, but look at the morphology, look at every layer. And the present OCTs help us in identifying very useful information, which helps us prognosticating and treating the patient proactively. Thank you very much.
Thank you, Dr. Kavita. I think from classifying DME types, we've come such a long way where we have to look at so many other prognostic markers, some of which help us actually decide treatment or to stop treatment. I have one or two questions if we don't have much from the audience. First question would be, are there any particular biomarkers or any particular features on OCT that you would look that will tell you for sure probably that you're going to have migration of hard exudate subfoveally? Is there some sort of an indication? Uni, would you like to take that?
No, it's probably that couple of things. One is when you have a cyst and it has a turbid content, that could be an example. And the second is the pearl necklace that is surrounding the cyst. You have a lot of clumps more than dots happening. So these are two things that could happen. The second thing that is interesting is there's been a few evaluations of the optical reflectivity of the content of the cyst. So there is a mathematical derivation based on the raw data from the OCT by which you can say that it is a totally lucent cyst or it has some content, and the more the content and the reflectivity is, the more the chances of having a subfoveal migration.
Great. Uni, which is your favorite marker for DME? Which is the one marker rather that you would definitely look at, because it's impossible to see all this in a busy practice, right? So if you have to ask you, which is the one thing that you would definitely, I mean, besides edema and subfoveal fluid and all that, which is the one marker as such that would help you make a better decision?
I am stumped at that question because DME is something that we look at the, when I am more successful treating a patient with DME just looking at the OCT from a meter away. The general impression it gives you about how the SMD resolves, how the CME resolves, which part of the retina is becoming thick again. The overview seems to be more important for me as of now than looking at whether the drill is progressing or not. Because to be in a practical sense, to know whether drill is recovering, you need to get the patient back at the right time, which never happens.
Exactly.
So you see what you get and you treat what you see is what we're doing in DME nowadays. Sorry for that.
No, that's okay. Anybody else? Any one thing? Yes, Dr. Nitin.
See, it all depends on what you're looking for in the thing. See, markers, like Uni also said, no, don't get too fixated onto markers. Still practice that same principle of looking at patient as a whole, systemic control, and don't go by markers that hyperfluorescent dots are there, you're going to give Osidex, this is there. But you have to look at the whole scene. Now, which marker is important depends on what you're looking at. Suppose you're looking at management of the patient. You look at subretinal fluid, that's important. It's important to tells you that systemically he's not okay. You have to look at his renal parameters. You have to look at that. So if you're looking at subretinal fluid, is something I always look at as a first thing is, do I start treatment now? Do I look at a systemic control first and then start treatment? If you're looking at when to stop treatment, then you'll be looking at something else again. You're looking at drill, you're looking at those large cystic cavities. You have given injections for ages and then it's still not responding. So in that stage, that OCT features will give you some guidelines as to when you're likely to start treatment. So it all depends what you look for. Most of the time we look at markers as a retrospect. We are managing treatment, they're not doing well, they're not responding. Then we go back, this guy has this guy has that. So at the moment, I don't think we're looking at markers from the treatment, deciding on the treatment, unless it's like like hyperreflective dots. Yes, you tend to tilt towards steroids in many other cases, in these cases. But I think biomarkers are something which is a sort of a stepping stone towards forming AI algorithms later. These things are going to look at markers for you and tell you how to treat. So probably we don't have to break our heads. The algorithm will tell you, you treat this with this is the prognosis, this is what is that. Probably we're still far away from that scope in that.
The reason why I asked Unni this question, sir, is that he's the one who began this education on these different terms of OCT in his conference, you know. Otherwise, we were like all stumped. Initially, we're like, do these names really even exist? So he's the one who started this whole thing, at least for us. One more question, ma'am. Do we have time?
Yeah, there is a question from the audience. Can you please?
There's an audience.
Yes, sir. So that question is, what are hyperreflective foci composed of? Inflammatory constituents or lipid? Dr. Kavita, you want to take that?
Yeah, they're actually basically lipoproteins because of breakdown of blood retinal barrier.
There's a controversy there. There's some issue about it being sort of activated microglia also.
Microglial cells, yes.
So
I
that's
think
why you have
that.
the AC contents higher.
Yeah, so there are, can I
have
take that?
increased
Yeah, only
protein
go
in the aqueous.
So essentially, we're looking at two types of hyperreflective foci. The one you see in atrophic diseases, and the second you see in vascular diseases. The one in vascular diseases are reasonably thought to be macrophages with lipofuscin content. But the ones that are seen in atrophic diseases are the ones that when they're activated or RP cells that have metabolized and they are leaving the RP in an atrophic event, that is the adherence or the addition to the RP. And therefore, the concept of an anterior migrating hyperreflective foci in RP disease and posterior migrating hyperreflective foci in vascular disease. That is, the hyperreflective dose goes towards the RP and get deposited underneath the retina on the subretinal space in vascular and go away from the RP in the opposite polar direction in atrophic disease.
Good.
And there's one more question.
I think we have to stop. Can we? We're already running a couple of minutes late.
Sure, ma'am.
Yeah.
The next question has been answered anyways.
Okay. Dr. Nitin, would you take the introduce next speaker, please?
Sure. Yeah. I would like to invite Dr. Unni again, Dr. Unni Krishnan he's going to talk to us about how to use OCT to prognosticate in macular surgeries. Dr. Unni is a consultant vitreoretinal surgeon at Chaitanya Eye Hospital. He conducts his famous Retina Imaging Congress, which is focused an international meeting on retinal imaging. He has numerous presentations at national and international forums, and he has numerous peer-reviewed research publications. Dr. Unni, can you take over?
Thank you for the kind introduction. And first on the outset, my congratulations to Dr. Muralidhar and Dr. Hemant for achieving a milestone and conducting this wonderful meeting. So I'm just going to start up. Okay. Yeah, so I would be talking about how to use the OCT to prognosticate in macular surgeries. So macular surgery is something that's both quite rewarding to the surgeon and also to the patient. But whenever there's something to gain, there's always something to lose sometimes, and we have to be quite accurate in all our decisions. So everything good outcome is based on acquiring the right amount of knowledge from whatever is available, including OCT, making the right decisions, promising the right outcomes, and explaining, having an explanation for unsatisfactory results. So I'll be just dealing with a few conditions, that your ERMs, the VMTs, and the macular holes. So first to ERMs. So the first point, are we operating the right patients when we take a patient for ERM surgery? And this is a major thing. There is an entity called lamellar hole associated epiretinal proliferation, in which you can see something that looks like an ERM, but you see a rounded margin and also an iso-reflective content inside, which is different from what epiretinal membrane looks like, where you have an epiretinal membrane with folds inside it. So this is what is called termed as a LHEP, or lamellar hole associated epiretinal proliferation, associated with, this is important, there's a rough, smooth, a double hump seen over here, lamellar defect with curved, rounded edges, and the presence of outer retinal damage, in which by definition, the LHEP is a reaction to a degenerative change in the retina. So this is some of our pictures in which you very interesting. This is a white on black appearance in which you can see the LHEP area is iso-reflective. It's a different reflectivity from the rest of the retina, and you can make it out in these 2 points that I'm showing you. And of all the modalities, we find that sometimes the infrared reflectance identifies the area of LHEP the best. So why is an LHEP important in macular surgery? One, there are variable views, but essentially one of the most important views is that an LHEP does not require to be operated. Why? 2 reasons. They are usually associated with a significant amount of outer retinal damage and thinning of the retina, hence a surgical outcome may not be ideal. And secondly, there is a high possibility of de-roofing and creating a full thickness macular hole. So what is an alternative that can be done is a fovea-limited peeling of the membrane, and inversion of the LHEP tissue inside the lamellar hole seems to be a better option than just doing a regular epiretinal membrane surgery and ripping it off. The next thing I'd like to talk about is the central bouquet. Okay, one of the most underestimated and ignored things is something called the Muller cell cone, which is a different type of Muller cell, a vertically oriented Muller cell exactly at the foveola attached to the photoreceptors. So as you see, when the traction increases, they pull and they can pull off the photoreceptors, causing a small gape, which we term as subretinal fluid. Over time, there are deposits of vitelliform nature of photoreceptor debris and a scarring process later. So this is what we see, what we mean by a central bouquet abnormality. And why is it important? The central bouquet is a tractional event. That is, a pull at the exact foveola causes an elevation of the central photoreceptor elements and eventually a substantial amount of irreversible damage, which could affect any result of an epiretinal surgery. So the implications it probably gives you a timing to tell whether an epiretinal membrane has to be operated or not. Let's hang on to this thought for some more time. The next thing I'd like to talk about is the IFL, or the ectopic inner foveal layer. So what does it mean? It means that at the fovea, you have a deficiency of all layers except the outer nuclear layer and the outer retinal bands. But when the adjacent layers are pulled into the center, you have the persistence of these layers, and these are called ectopic inner foveal layers at the foveola. So what does this mean? So there has been the presence of IFL has been introduced into the staging system of ERMs nowadays. And why it is important is that it's a poor prognostic feature or a poor surgical outcome. That is, vitrectomy and ERM removal does not improve vision significantly in patients with IFL. And what is the importance of you can see these patients with IFL having, even after the successful removal of the epiretinal membrane, the inner retinal elements do not move away from the foveola center. So what can we say? That the consensus is that in patients where there's already loss of the ellipsoid zone, as seen sometimes in the presence of LHEPs, when there is a significant central bouquet abnormality and in the presence of IFL, these are some of the features where we should not operate. Okay, this is an interesting thing that has to complete. I have to talk as the presence of an epiretinal membrane mimic. Seen in younger patients, what you can see here is huge infoldings of the inner retina to the outer retina, and this is what has been described as the omega sign. The omega sign is like when they're in the presence of a combined hematoma of the retina and the RP. It looks like an epiretinal membrane, but you can burn your fingers if you tend to operate this patient. So you can see that this is like an outward push of the inner retinal elements because of the contraction of the surface of the inner retinal surface. So there are identification of this is by something called mini peaks and maxi peaks. Mini peaks are the small peaks you see under the surface of the epiretinal membrane. The maxi peaks are the huge undulating omega signs that you see. And whenever you see a maxi peak, you can think of irreversibility of the retinal structure after ERM removal. So I'd like to point out the lessons. Operate after ensuring the diagnosis. That's what the LHEP tells you. Operate before irreversibility. That is what the presence of IFL tells you. Operate before outer retinal damage. That is what this looking at the central bouquet tells you. Operate after assessing the prognosis. Look at the outer retinal health and do not touch some types of ERMs when you're suspicious of them. Now, talking about VMTs and macular holes, are they lost causes always? Are we just do our eyes just gleam when we see macular holes? So there's a definition of VMT by the international the VMT classification group. I'm not going to some of these details, but these are the patients we see. It looks quite bad, and then it just separates spontaneously, and then you have a small lucency there, and over a period of 16 weeks, it's just as if nothing has been touched. They go both ways. Sometimes they go and tear more and create larger lamellar holes and full thickness macular holes, and sometimes they don't. So in several series, what is learned is that in the early stages, when you have narrow attachments, up to 53% of them spontaneously resolve. This is something you can tell your patients between 15 to 18 months. But if the patient has got a progressive central distortion, that is something we have to be careful of by offering earlier surgery. So the presence of a VMT is important, because you can see in these patients, this is a spontaneous detachment. And if you look at the lowermost portion, there is a surface contour change, which is most probably the best evidence, historical evidence, that this patient had a released VMT. Other studies talk about persistence of VMTs and resolution, but the most important few points are that this is the best outcome. When you have a small VMT less than 1500, the CFT is not increased, and you have noticed a short duration, these are better outcomes. They may detach by themselves. But when should you really operate? When there's a larger duration of symptoms, when there are premacular membranes in addition to the VMT, when there's a very thick retina and a broad configuration, and you see separation of both the inner and outer foveal layers. Just coming to macular holes. Do holes close by themselves? Yes, we are just agents that help some of the holes. 50% of early holes close by themselves, but as the stage increases, the tendency to close is less, therefore we intervene. And that's what we're trained for. Hole closure is better when the holes are small, this we know, and when the stage of the hole is earlier. As it progresses to a stage 4 hole, intervention is a better tool. So this is a study that we look at, that in medium and large macular holes, the hole closure by conventional ILM peeling is quite as good as that by inverted. But when you go to holes larger than 400 microns, the closure rates are better with inverted ILM peeling. So this is a study which told us just chronic macular holes, the size of the hole is more favorable to a type 1 closure. Larger than 1200s don't close. This is before this study did not include inverted ILM flaps, but it's good to know that holes of 3.3, more than 3.3 years of age, and large holes are less likely to close. So there are options for ultra large holes. We're not going to surgical techniques, and this is important. The OCT tells us what type of technique to use also. So it's an important point to know. So these are really large holes, and you can see this particular hole has an astronaut sitting in the center holding to the two edges. And this is another type of hole that closed, which you have exuberant tissue that started happening after a couple of months. Again, different types of inverted ILM flaps, different shapes. So what are the prognostic features besides having a less duration of symptoms and good preoperative vision? The stage of the hole and the size of the hole are quite important. There are a whole lot of indices. This is my most favorite slide to slip, because I really cannot make head or sense out of it. When I see something like this, I'd rather operate than sit and measure it. But what it tells us is quite important. When the minimum inlet diameter and the basal hole diameter are more important a feature to assess type 1 closure, which means that the horizontal measurements seem to be more important than vertical measurements in closure of a hole. Having said that, when you look at these two holes, a hole that does not have a height element, you are quite worried that it will not close. Rather than a hole that has cystoid macular edema and an element of height, you expect that the edges come to close. So this is something that is ingrained in our minds. So here you see holes are closed easily with a height element. Again, a good closure hole. Here you see a good height and you think it's going to close, but it's closed with a gap. This is a flat open configuration. So again, another study that says that the basal diameter, which for all practical purposes seem to be the most important index for hole closure. So this is a hole that did not close after the first surgery, and with a re-surgery it closed later. Again, it was waiting to close probably. Post-operative features on OCT, the integrity of the ellipsoid zone for visual improvement and the type of closure. So there are types of closure, type 1 and type 2, as we know, also called flat open or elevated open. But the type 1 closure was consistent with a better visual acuity. This is things we know. Even the type 1 has been divided into U, V, and W. W, in which there has been lots of foveal atrophy causing an irregular surface and extreme thinning of the retina. The outer retinal health is also is extremely important. The graded at 0 to 2, and obviously it goes without saying that a good photoreceptor integrity is the best prognostic factor for postoperative visual acuity. Now coming to the ELM.
You have to summarize only, sorry.
Yeah, I've just finished. Okay. So these are NFAS slides showing the closure over time of the ellipsoid zone. So this is one of our papers in which we've looked at a new index called the external limiting angle, in which we find out we've taken an angle between the edges of the external limiting membrane to see that after surgery whether the ELM closes properly and forms a scaffolding for the photoreceptor layer. Another interesting paper we've done is that we've looked at the displacement of the center of the fovea after macular hole surgery. And we found out that the center of the fovea can go temporally and sometimes even nasally after closure, depending on which of the limbs or which of the is higher and longer. Some of the most interesting work that has been going on now is the presence of relating the intraretinal cysts with metamorphopsia. So to conclude, I'd say that macular holes close. They need your help sometimes. Don't be overzealous. You can look at as many indexes as you want to and create a few if you want to. There's a lot of scope of creating new indexes. Most important, communicate with your patient properly before closure and also after closure. And also be very aware of outer retinal health being one of the most important features of having a happy patient and a happy closure. Thank you very much.
Thank you very much, Rooney. I think that was a very, very comprehensive coverage, a lot of learning. I think you really summarized almost all of the macular surgeries that we do. And I like your conclusion side saying that sometimes they need our help. Taking a 50% of our surgical work. Yes, sometimes they need our help. Okay, so there are no audience questions. I'm just quickly going to invite, a couple of comments. Dr. Nitin, would you like to comment?
Nothing specific. I think Unni's covered it very, very well.
I think so. I would agree.
Introduced a few more terms to confuse all of us again.
He's a master of terminology. So
ERMs with this lamellar hole associated ERMs, when you actually operate them, those membranes, we sometimes mistake them for ERM. They actually behave a little differently when you're operating them. They're a little more mushier. They don't come out like a membrane in that time. So it's important not to confuse them for ILM or ERM in that time. Know the OCT findings before you touch them in that time, what Dr. Unni has told in that time. Absolutely. Apart from that, like macular hole, he said, like most of the decisions are taken on your clinical examination and on the OCT findings at the first go. We very rarely look at the various indices that are described. And it's important to clinically assess before you really take a decision on surgeries. If you look at how healthy the RP, how healthy the retina, the associate changes, and that's what helps you make the decision. That I think rest of the things are very well covered by Unni in this.
Absolutely, yeah. Are there any other comments from anyone on the panel?
I think just because we're talking about surgery, intra OCT also, I think some have experience with respect to surgery since we're speaking about that.
We have an entire talk on intra OCT,
so
I think.
That would be
so I think we will, yeah. So let's, thank you so much, Unni. So let's move on to the next talk. Can I invite Dr. Mahesh Shanmugam for his talk? OCTA. I don't think Dr. MPS requires, absolutely an introduction at all. I think I would just sum up and say one of our favorite all-time teachers. Everything else. He's the head of retina and oncology at, Shankara. I think, is apart from retina, has, ocular oncology, one of the foremost ocular oncologists in India. So, sir, over to you, please.
Thank you, Dr. Rajni. I think somebody has to stop sharing so that I can share my slides. Yeah. Okay, fine. Can see my slides?
Yes, sir. We can see and we can hear you. Yes.
Oh, okay, sure. Thank you, Dr. Rajni. Thank you, Dr. Murli and Hemant, for this opportunity to meet everyone this evening. And congratulations once again. So the talk given to me is OCTA. What is the current status of clinical practice? So let's look at it like this. So are there things that I cannot live without? Is OCTA something that I cannot live without right now, or is it something which I can live with? So it's going to be 10 points. So you'll know where I am in the talk and when I'm going to finish. So PCV is something which we have to diagnose with ICG. Is it possible to diagnose PCV without ICG? So here is one such patient with probably a hemorrhagic pigment epithelial detachment, and the FFA doesn't show much, except possibly this is where the PCV is. And if we do an ICG angiogram, it shows the branching vascular network as well as the polyps. But in contrast, the OCTA does not show the polyps. It just shows the branching vascular network, which can be mistaken as a coronary membrane. Seldom does the polyp and the BVN seen, and this is one such patient. So here you do see the polyp on the BVN, but this is not a common occurrence with OCTA. So is it possible to diagnose PCV with OCT and OCTA? Yes, Dr. Chung has come up with this idea of combining both these together, and has given guidelines with which we may be able to diagnose PCV with just these two instruments. On OCT, what do we look for? We look for a pigment epithelial detachment, a double layer sign, and a peaked and notched pigment epithelial detachment, and a round sub-RP hyporeflective lesion. In addition, the cross-sectional OCTA shows that there is a sub-RP hyperflow signal. I'll show you what this is. So these are the factors which we look for in the OCT. So here we see a peaked pigment epithelial detachment, or thumb-like pigment epithelial detachment, a double layer sign, and we see the sub-RP hyporeflective lesion. And if you were to do an OCTA on this, not the on-face OCTA, but the cross-sectional OCTA, here we see the focal sub-RP hyperflow signal. The presence of all these factors together indicate that this patient may have a PCV. So when they did a study, they found that with combining these factors of OCT and OCTA together, we are able to diagnose PCV with about 83% sensitivity and 100% specificity. And it may not be necessary to do an ICG in all these patients. So do we still need ICG and FFA in PCV? As long as we treat with only anti-VEGF, it's not necessary, because it's kind of a broad-based treatment. We are not focusing the treatment on anything. But if you were to do focal laser or photodynamic therapy, and invasive angiography may be necessary, because the PDT is once again a broad-based treatment, and focal laser is something for which you may have to do an ICG still. Now, moving on to age-related macular degeneration. This is a patient with bilateral age-related macular degeneration. I've been following him up, and there is no subretinal fluid or intraretinal fluid. And when we see here, there is a break in the outer retina, and the fundus fluorescein angiogram did not show anything. But when we did the OCTA, it did show this neovascularization. So this macular neovascularization, which is quiescent and which is not leaking, is something which is known as a non-exudative CNVM. At the present moment, the indication for treatment is the presence of subretinal fluid or intraretinal fluid. So this particular CNVM, which is a non-exudative CNVM, is something which we don't treat. But what it tells us is to follow up this patient a little bit more closely. And promptly, in about a month's time, this patient developed subretinal fluid. And you can see the morphology of the coronal neovascularization has changed on the OCTA. So the OCTA does give us some indication as to which CNVM can leak or which CNVM is going to become active. An active CNVM on branching shows multiple capillaries, but an inactive CNVM shows large mature vessels. And anastomosis and loops are present in the active CNVM, which are absent in an inactive CNVM. And vessels terminate as peripheral loops, which is kind of a dead tree appearance in an inactive CNVM. And this perivascular halo is something which hypopigmented halo is something which we see in an active CNVM. So point number 2, non-exudative CNVM, as of now, we don't treat, but OCTA lets us predict and detect worsening early so that we can follow up the patient much more closely. Here is another patient who has subretinal hyperreflective material, and the OCTA does not show any network. But when we look at the cross-sectional OCTA, it shows a detectable flow in the strip. So what it indicates, but the fluorescein angiogram and ICG angiogram do show some amount of leakage. And 2 weeks later, promptly the patient developed the subretinal fluid. So what it indicates is that OCTA detects vascular strem even in the absence of a network, indicating that these are patients which we would want to follow up closely because they may develop activity. And this post-treatment, you can see that there is no fluid and the strem has also resolved. Now moving on to diabetic retinopathy, when do we do fluorescein angiogram? Fluorescein angiogram helps us identify leaking microaneurysms, identifies macular ischemia, and also in proliferative diabetic retinopathy, it identifies neovascularization and areas of peripheral capillary non-perfusion. So the OCTA does show the integrity of the foveal vascular zone and the microaneurysms quite well without the need for injecting a dye, particularly important when the patient has a nephropathy as well. But what we need to understand is not all microaneurysms are shown up on the OCTA. Another thing is like the OCTA helps us prognosticate. So the deep capillary plexus is affected. If it is affected, the visual acuity may not improve even after edema regression when we treat this patient with anti-VEGF agents. So this is something the OCTA is capable of telling us, with the other angiograms cannot tell us. And proliferative disease, yes, a clinically unapparent NVD can be picked up, and Octa helps us identify NVE. And it also helps us clarify if it is IRMA or NVE. The NVE is above the internal limiting membrane. And what it does not tell us at the present moment is the peripheral areas of capillary non-perfusion and peripheral NVE, at least the current machines. But some of the newer machines are able to give us a wide field Octa, which tells us about the capillary non-perfusion status as well as the neovascularization elsewhere. So even if we have a regular machine, we can make it wide field by putting a +20 diopter lens or a +60 lens. We can hold it in front and take the machine closer, and we should be able to get a wide field Octa with our existing machine as well. Now moving on to Octa and central serous chorioretinopathy, of course, it shows the OCT shows the presence of subretinal fluid, but Octa, does it have any specific role? So it helps us identify the pachychoroid neovasculopathy. Many of our patients with CSC may have a pachychoroid, and they may have a pachychoroid neovasculopathy, which may not be picked up on OCT or on FFA. The pachychoroid neovasculopathy is picked up better with the Octa. In addition, there's a new paper which shows us, like Octa does not show leakage in CSC, but there's a paper which helps us identify the area of leakage. So what they have come up with is, they call this as the choriocapillary island. So there is an area of hyporeflectivity, and in the center you see this increased reflectivity, and that corresponds to increased blood flow here, and this is possibly the area where it leaks. This is one of our patients, and this shows the leakage. And we see the area of leakage is where there is a hyperflow on cross-sectional OCTA, and you can see this hypofluorescence, or what we call as this hyporeflectivity, and this island, the choriocapillary island, which is where it can leak from. So CSC identifies underlying macular neovascularization, and it can give us a guide as to where it is leaking from as well. Parafoveal telangiectasia type 2A with choroidal neovascular membrane. The Octa shows that in addition to the choroidal neovascular membrane, shows that the superficial capillary plexus and deep capillary plexus changes. And the CNVM is beautifully picked up. And FFA sometimes can be confusing whether it is leaking from the PFT or from the CNVM. But the Octa shows that the neovascular network in the deeper layers and how well it is shown up on this, this picture can be seen. So the other eye of the same patient, there is some indication this patient may have a PFT as well. But what it shows is that the superficial capillary plexus is intact, and it's the deep capillary plexus which is affected in parafoveal telangiectasia. And this layering is something which is not possible with the regular angiogram, but the OCTA is the one which shows us that. And here is a patient who underwent a fluorescent angiogram. It shows some amount of PFT kind of leakage, and there is some leakage here which possibly indicates a neovascularization. But the Octa shows that this patient has an epiretinal neovascularization. So we have come to identify this particular subset of parafoveal telangiectasia, which shows that epiretinal neovascularization, and it's Octa which shows us this. So Octa and PFT identifies CNVM and many other things as well. And number 7, and this is a patient with Best disease and shows some amount of deposit which is common in Best disease, and some amount of hyperfluorescence and fluorescent angiogram which may or may not indicate anything. But it's the Octa which shows us the presence of neovascularization in this. So similarly, Octa identifies PVAC, because otherwise it will show up as some kind of a leakage in the perifoveal area. But Octa, by its layering, it is able to tell us where this particular neovascular complex exists, and it's essentially within the retina. Coming on to tumors, Octa is very, very helpful in differentiating melanoma versus nevus. This is a very small melanoma here, and this is a nevus. So melanoma has ill-defined margins, whereas the nevus has well-defined margins, and hyporeflective choriocapillaries in melanoma, whereas it is hyperreflective in nevus, and avascular areas are more common in melanoma in contrast to the nevus, and choroidal vascular changes are also more common in melanoma. It also helps us differentiate between melanoma and melanocytoma. Melanoma shows the network, in contrast to melanocytoma doesn't show a network. This is one such patient whom we had treated with brachytherapy, and though the tumor as such looks the same, whether the brachy is working or not can be shown up with Octa. You can see the blood vessels are decreasing, and you can see this hyperflow is decreasing, indicating the brachytherapy has had an effect on this tumor. And tumor microvasculature is of prognostic importance in melanoma, and this is something which can be picked up to some extent in the OCTA as well. The OCTA in melanoma differentiates the differential diagnosis like melanocytoma and helps us prognosticate as well. So this is a patient with choroidal osteoma, and osteoma, yes, it detects the osteoma network as well as the choroidal neovascularization, which is associated with it quite well. And OCTA, in addition to all the ocular diseases, is able to be a window to systemic disease. So here is a patient with Alzheimer's disease with an age-matched control. You can see the capillary network being much sparser in Alzheimer's disease. It is also able to help in identifying optic neuropathies as well. So OCTA does help, and this is not something which you may live with or not live with, but there are many things in the world which are not really necessary, but we still live with. And if you're one of those who can live without anything, probably you must be living in the Himalayas and coming down once in 12 years to have a bath. But otherwise, then OCTA is for you. Thank you very much for your kind attention.
Thank you, sir. Excellent talk as usual, with the killing punchline there at the end of it. Sir, some doubts, some questions. What is your take on OCTA for myopic CNVM, sir? Because sometimes they're so subtle, they may not always be picked up on other imaging modalities. So what is your take on myopic CNVM?
Yeah, I agree with you that like OCTA may not be particularly useful in myopic CNVM, and the fundus fluorescein angiogram would be the best way to pick up a myopic CNVM. Unless like we're able to do a much closer raster scan, it can still pick it up, but then I would prefer a fluorescein angiogram. That would be one of the indications for a definite fluorescein angiogram.
So there's one question from the audience, Dr. Deepak Kumar. He asked, can we laser CSCR only based on OCTA localization?
At the present moment, no, but as I showed you, this is a recent paper which kind of gives us a clue as to where it can be leaking from. I would still do a fluorescein angiogram, but OCTA does help us if there is an associated pachychoroid neovasculopathy or anything else. So I would still do a fluorescein angiogram before I do a focal laser in a CSC.
So how often do you follow your patients, CNVM patients, the vasculature on OCTA itself? Like, for example, post-injection for CNVMs, we call them for OCTs once a month. On OCTA, how often do you follow? Is it the same?
Yeah, I would do an OCTA every time I do an OCT in a patient with age-related macular degeneration, unless the clinic is very busy and it's going to hold up the machine. But most of the time, yes, I would, because like, again, this is like we are in the phase of learning with OCTA. So though these are the indications which have been kind of proven, so there are still many more indications which are likely to come up in the future. So the more we look at it, the more we find. So I would do in many of these patients.
So one last, before we ask if anybody else has that thing that you like, knowing fully well that you are such a great innovator with very small things. How did you manage to get a wide field OCTA, sir? Because I don't think all of us can afford a Plex Elite. So how did you actually manage to get a larger field, and how wide was the field?
Yeah, this was what Dr. Divyansh had presented last year or 2 years back in AOS. So the simplest way is to put a trial frame or put a 20 diopter lens onto the trial frame. So what it makes is it takes the machine much closer and gives us a wider field. So with the 20 diopter lens, we should be able to see just up to the equator. But holding a 90 diopter lens in front, and like the only thing is a little bit of coordination. So the patient should not move and the lens should be stable. We can see just about like almost about beyond the equator. If I remember right, probably like 2.5 or 3 times more is what we can see. So not as good as the machines which have an inbuilt software, but like it's pretty good enough if with whatever existing machine we have.
Anyone else? Any other questions? Ma'am, do we have time? There's one more question.
Yeah, we have just about a minute, yes.
Role of OCTA in arterial occlusion, CRAO or BRAO?
I can't say that I have done too many of those, but I'm not too sure if it's going to help you much, because like the blood flow, yes, it can show, but then like it's, I don't think I have done too many of those to comment on that.
I think we've published one, sir. We were just able to show that pre and post paracentesis, there was some restoration of flow.
Network.
It did not really translate to visual improvement because the patient came late, but at least you're able to tell that, paracentesis may actually help restore. Anything, if nothing else, ma'am, we can go to the next.
Yeah, can I request Dr. Nitin?
The next topic will be on pachychoroid spectrum and diagnosis and clinical aspects by Dr. Naresh Yadav.
I'll start sharing.
Yeah. Dr. Naresh Yadav heads the retina services at Narayan Nethralaya in Bangalore. He's got his retina fellowship from SN and FRCS in 2006, has over 50 publications in various national and international journals, and special interest in vitreomacular interface disorders and TRD surgeries. Dr. Naresh, please.
Thanks, sir.
Naresh, I think you have to open your presentation and then...
It's open now?
No, it will not be open. You need to open it first and then share.
Yeah.
Oh, you double click that, sir, at least.
It will not come, Mama, because it will not share.
I'll stop sharing then.
You stop sharing. And
I think so.
You
Yeah.
open your presentation and then you start sharing. Then it will come.
Is it seen now?
No, we are not seeing it. That's why.
No.
I didn't the show.
Naresh, what you do is you stop sharing, you minimize the zoom, and then you put on your presentation first, and then put the zoom back and then start sharing. So you have to do this circus, otherwise it will not come.
I don't know what has happened. Okay. I'll minimize the zoom.
Then open your presentation and then just click on the zoom, that icon that is there at the lower bottom, and then it will come back. Your zoom will come back and then you start sharing.
Is it seen now, or I'll share screen now?
Yeah, share
Okay.
screen. Yes, now it's coming.
Yeah.
Good.
Okay. Sorry for the inconvenience. At the outset, I'd like to thank Team RIK on the Silver Jubilee and for the opportunity given to me. I'll be speaking on pachychoroid spectrum.
It's still not on slideshow, Naresh.
Okay.
Yeah, now it's.
Yeah. So by pachychoroid spectrum, we mean a group of macular disorders having similar choroidal findings, and it has overlapping features, and progression from one disorder to another is frequently observed. So this is just to refresh. The hallux layer sort of constitutes of large caliber vessels which are non-fenestrated, and the Sattler's layer has smaller vessels, and the choriocapillaries is composed of richly anastomotic capillaries which are fenestrated. So I just want to make it very clear that thick choroid is not mandatory for pachychoroid phenotype. You have to look more at the morphology of the choroid. So the most salient point is dilated vessels in the hallux layer. So these are known as pachy vessels. As you can see here, it is in the dilated vessels in the hallux layer. These are known as pachy vessels. And overlying this, the Sattler's layers and the choriocapillaries can get attenuated. And this brings the pachy vessels closer to the Brook-RP complex. And the other thing is, wherever you see the thickened choroid or the pachy vessels, the retinal disease or the RP abnormality usually co-localizes there. So in that area only you find the most changes. So ICGA also is very important. So on ICGA, you can see there's a cluster of relatively straight and dilated choroidal vessels. There can be choroidal venous dilatation, choroidal filling defects, delayed arterial filling, and hyperfluorescent areas observed from 7 to 15 minutes of ICGA. So here you can see the dilated choroidal vessels, and there is a hyperfluorescence seen on the ICGA. So the pathophysiology, what happens is there is inward displacement of the congested Pachy vessels, and this causes atrophy of the choriocapillaries, and this leads to disruption of the RP and the Brooks. So how the RP and the Brooks membrane resist this choroidal pressure will determine the development of different forms of pachychoroid disease, which we'll see in the later slides. So basically, the pachychoroid spectrum constitutes of pachychoroid pigment epitheliopathy, central serous chorioretinopathy, pachychoroid neovasculopathy, PCV, peripapillary pachychoroid syndrome, and focal choroidal excavation. So pachychoroid pigment epitheliopathy, here it was described by Varro in 2013. It constitutes of non-specific RP changes usually seen in the other eye of a CSCR patient. And as you can see in the diagram, the RP changes usually overlie the area of choroidal thickening, or wherever the choroidal changes are there, it will co-localize to that area. And there is no SRF in the PPE. And the Pachy vessels come close to the RP Brooks membrane complex, and that can mechanically irritate the RP and cause PP. So here you can see the FFA is very good to pick up these RP abnormalities, and the ICG shows the dilated Pachy vessels. So why it is important to diagnose or to follow up these patients who have PP? Because around 18% of these patients developed CSCR in this study. So it's a sort of forme fruste of CSCR. So it could be a precursor lesion for the pachychoroid spectrum of the disease. So whenever you see a patient who has PPE, so it's better to tell them that a closer follow-up is required, and you could give them the home Amstlers also. It's not a sort of very benign disease, so needs a closer follow-up. So basically, this is one of our patient, 35-year-old male. So on fundus, we could see some RP changes, and on the OCT, you can see the large Pachy vessels, the choroid is thick, and this is the magnified image. Here you can see there are two small areas of PED. And this patient, after 5 years, he came to us with decreased vision. And then you can see there's an acute CSCR. And the Pachy vessel is so nicely seen. And on top of that, you can see a sort of irregular PED. So this slide shows the conversion of PP into sort of active CSCR. So now we'll talk of the CSCR. We know that the choroid is thicker in eyes with both active and inactive contralateral eyes. There is vascular hyperpermeability, which increases the choroidal vascular pressure, and this damages the RP, causing PED and subretinal detachment. And studies have shown that the choriocapillary vessel density is lower in CSCR as compared to PPE. So why should we look at the choroid in CSCR? Because studies have shown that if there is a higher subfoveal choroidal thickness, there are more chances that the patient will have recurrences. And the thicker choroid patients, it also influences the episode duration, and there's a worse disease course also. And we always tell the patient that we will do the laser for acute CSCR, but it's not going to reduce the recurrence rate, because the laser itself does not cause vascular remodeling. It causes no change in the vascular morphology of the choroid. And Dr. Chablani also had shown that even with early laser, the choroidal vascular index does not show any change. That is the reason that laser does not really modify the disease of the CSCR. So the CSCR treatment, we should target the choroidal vascular dysfunction. But unfortunately, PTT is not really available now, but PTT has been shown to sort of remodel the choroid, and it decreases the choroidal vascular hyperpermeability, and the patients can be sort of remission. They can be in remission for longer period of time. Micropulse also has been used. We had a publication on that, but pharmacotherapy seems to be an interesting option because we know that steroids can cause choroidal thickness and hyperpermeability. So we used oral eplerenone to treat acute cases of CSCR, and we compared with in one arm we did not treat. So we found that oral eplerenone achieves faster SRF resolution and vision improvement in acute CSCR. Additionally, it shows beneficial effects on the other eye. So that also was very interesting. So this is one of the patients from that study. So you can see the with oral eplerenone, the other eye also showed that CFST had reduced from 284 to 277. And this is the eye with the acute CSCR. There was a good resolution, total resolution of the subretinal fluid with reduction in the CFCT. And this is another patient. So here you can see there's an acute CSCR, choroidal thickness was 520. It came to 348. And the other eye also showed decrease in the choroidal thickness. So this could be important because we can directly tackle the choroidal pathology. And there is a likelihood that in the long term, this could be useful. But longer studies are required. But this study, I thought I'll share with you because we found it very interesting. And now we'll talk of the pachychoroid neovasculopathy. So it can develop after chronic CSCR, and it may progress to PCV in some cases. It's a sort of formophrasty of PCV. Kunal Das Singhani showed that he used Octa and angiography to examine 22 eyes with pachychoroid features and shallow irregular PEDs and found type 1 NV in 21% of the eye. But most of the studies show that the CNV detection rate is between 25 to 36%. That could depend upon what machine you are using and how careful you are doing in or performing in Octa. So many times this could be a benign and often underdiagnosed condition. So this is one of our patient, 48-year-old male, and diminished vision since 5 months. So he came for a second opinion to us, and we found there's a flat irregular pigment epithelial detachment. And FFA was not really very helpful. You just see a ill-defined area of hyperfluorescence. But if you see the Octa, you can see the neovascularization here. And the patient received anti-VEGF. One thing with the pachyneovasculopathy is that these are more sort of mature vessels. The morphology does not really change much once you give anti-VEGF. So the response is not that dramatic that you get in AMD. So this is another patient, 48-year-old female, second attack. And based on the FFA, I thought there's a sort of leak here. So patient underwent laser treatment, but there was no resolution even after 4 months. And then we did the Octa. One thing you have to remember is that type 1 CNVMs many times can be missed if you just rely on the automated segmentation. So manual segmentation is very crucial to pick up membranes that are below the RPE. So there's a link between CSCR, PNV, and PCV. So excess endoluminal stress resulting from high flow rates, BP exceeding values tolerated by PCV, by the CNV, or both can lead to aneurysms. So basically, a type 1 CNVM can develop aneurysms at the margins. So Adrian Fung et al. Showed that 36% of their patients with chronic CSCR and type 1 NV went on to develop PCV. And George Maniat also showed that around 3.7% of the PCV cases had typical CSCR-like leak in the same eye. So this is one of our patients. This is a photograph. You can see the subretinal nodule here. There is fluid at the fovea. So I got the OCT done. So I was very surprised this amount of subretinal fluid in a case of PCV. So then we got the FFA ICG done. So this left eye also shows serous PED, and there was a small subretinal nodule here. And this is the corresponding OCT. You can see there's a sharp peaked PED here. Similarly, this sharp peak PED that is most likely going to coincide with the polyps. And this is the FFI ICG. The right eye, you can see there's a typical smokestack type of leak, and the polyps were seen. And the left eye did not show the CSR type leak. This is just a solitary polyp.
Naresh?
Yeah.
You have 1 minute, Naresh.
Yeah, okay. So this is another case. We can see a flat, irregular PED. And after 5 years, the extent had increased. And then the patient came to us again after 2 years. And then there's a sharp PED that we could pick it up. And then the Octa showed, ICG showed that it has converted into PCV. So basically, there's a pachychoroid spectrum progression. So if the RP is able to withstand the choroidal pressure, the patient just remains in the uncomplicated pachychoroid phenotype. But some eyes developed RP dysfunction leading to features of PP, and further RP damage causes breakdown of the RP barrier, and choriocapillaries loss causes CSCR, and further choriocapillaries attenuation and loss produces an ischemic milieu, and this can cause neovascularization. And finally, aneurysms may develop in long-standing neovascularization. Thanks for a patient hearing. I am not really covering the, I think because of the shortage of time, but this is an interesting case. This is a choroidal osteoma that we are following up. You can see the ultrasound, it shows the sort of double optic disc. So this is because of the choroidal osteoma. And this, you can see there's a little decalcification that has happened here. And this patient went on to develop focal choroidal excavation. So this could be because of the decalcification that happened, or because of the osteoclastic activity. So, but these patients have to be followed up. We are planning to do Octa, whether to see whether we are not missing some CNVM or CSCR, but I found this case interesting. So you can see how it has flattened. And these are the spongy bony trabeculae that you can see in the osteoma. And this is the, just recently we saw, it has caused a focal choroidal excavation. Thanks, that's all.
Thank you, sir. Extensive. Now that pachychoroid is there in our life, we might as well, know its importance. At one point, I think we didn't want to accept there's even something like that. Any comments from the rest of the panel? Or we have Jay there, who is quite the expert for choroidal imaging. Anything you'd like to add, Jay?
Hi, everybody. Yeah, thanks for asking me to comment. Yeah, very nice talk, Naresh, sir. The only thing I can say that now the mystery of pachychoroid is getting slightly, I would not say clearer, but still we are getting closer to call it as congestive venous disease, because we believe that this is primarily because of the venous overload choroidopathy. I'll be covering that up a little bit in my talk, but with the help of Whitefield ICG, now we are able to understand how these choroidal vessels get engorged and dilated, and how they are draining towards the vortex vein, and the actual role of vortex vein in this pachychoroid spectrum. But I would not take too much of time, and if others have any comment or question, that would be really nice.
I have a comment if no one else has anything, Chaitra. So we found that in patients with retinal dystrophies who are associated with angle closure glaucomas, for example, in bestrophinopathies, many of them, 50% have angle closure glaucoma. So all of these are significantly associated with the pachychoroid spectrum. So we found that patients who have a thicker choroid, a pachychoroid, probably have a higher risk for angle closure glaucomas compared to those that don't. I think a lot of patients need to be looked at, but that was something very interesting where we found that pachychoroid is with angle closure glaucomas.
Can I add one?
For a retina person to check that than actually getting a gonio done every time.
Yeah.
Can I add
Guru Prasad, sorry, Dr. Giridhar wanted to say.
Yeah, I mean, you finished what you were saying, Rajni.
That's all, sir. So Chaitra was, I think, commenting on that. Yeah.
Yeah. No, it was a nice talk, Naresh. I think Jai, and also Uni is there. I mean, the thing you'll agree that there is much of general the CSCR, neovascularization, and pachychoroid neovasculopathy. Now, you see two cases which Naresh showed, where he showed a flat irregular PED progressing into a CS macular detachment. Now, we really don't know. There may be, if you go on Octa in that case, you may see a network. So we really don't know whether that's a CSCR or whether that's a type 1 CNVM unless we do an Octa. So there is, I mean, recently there was a paper that was published just about 2 months ago in Retina on CNVM in CSCR. Now, if you see, they have shown, I mean, in that article, I don't know whether Jai saw that article, a very controversial article where they have shown that the neovascularization in CSCR is not, it is type 1. But actually, all those cases that they have shown there are all PCN, type 1 neovascularization, and all patients are above the age of 50 years. So I think we need to work very hard to understand, and there's a lot of overlap now, CSCR, PCN, CSCR, CNVM. So there is a lot of confusion as far as understanding these definitions as of now. And that particular is a very interesting read, and definitely, I mean, a very controversial area. So, I mean, I really, I mean, I don't know, but then I think we need to work on it.
Okay, so.
Thank you, sir. Dr. Nitin?
No further. Nothing
So
to add.
shall we wind up the session then, Dr. Nitin?
Sure.
Yeah, thank you, Dr. Nitin, Dr. Rajni, and Dr. Chaitra for conducting this first session. And we had excellent talks from Dr. Manjula, Dr. Kavita, Dr. Unni, Dr. Mahesh, and Dr. Naresh. I think we have added a lot more to our knowledge. Thank you all very much.
Thank you.
Thank you, sir. Congratulations again.
Thank you.
Very much.
Yeah, Murli.
Thank you. Thank you, everyone. We move on to the second session for this evening, again on imaging itself. And I have great pleasure to thank Novartis, who are the presenters, who are the sponsors for this session. And for this session, I have great pleasure in inviting Dr. K.S. Kumar as chairman and Dr. Praveen Murthy to co-chair the session. And to moderate the session, we have Dr. Purna Chandra. The three of them are well known in the vitreoretinal field, but still I'll just put in a word. K.S. Kumar is one of the well-known vitreoretinal surgeons of Karnataka state. He is a post-graduation from PGI Chandigarh and Shankar Nethralaya retinal training, and then further with Dr. Ando. He is a very prominent figure in all India meetings. He presents papers, he conducts instruction courses, and well-known figure. And Dr. Praveen Murthy is the fourth generation ophthalmologist. He belongs to the family of fourth generation of ophthalmologists. And as what we can expect from a fourth generation ophthalmologist, he has done well and he has exceeded the expectations. And with his family, he has taken the Prabha Eye Clinic to greater heights. Is again a well-known figure, well-known vitreoretinal surgeon. Dr. Purna Chandra is a young vitreoretinal surgeon, but well-known, and he has got his interest in the field of retinal dystrophies and degeneration retinal dystrophies, genetic eye diseases, and also in electrophysiology. And he is a very dynamic person who runs the Bangalore Retina Club very well. So we have the pleasure in inviting this team to take over the second session. Over to Dr. Kumar.
Thank you, Dr. Muralidhar, for the kind words and for letting us conduct the second session. I welcome on board my dear friends, Dr. Praveen Murthy and Dr. Purna Chandra. Although it may sound hackneyed, it is incumbent on our part to once again congratulate Dr. Muralidhar and Dr. Hemant Murthy and their team for a wonderful journey so far, and wish them all success in the years ahead. The aroma and flavor continues to be imaging even in the second session, and we have 5 speakers in this session, 2 of them from abroad, Dr. J. Chablani and Dr. Prithvi Muchunjaya. Without wasting much time, I now have great pleasure in introducing Dr. J. Chablani. He's a vitreoretinal specialist currently at the University of Pittsburgh in the USA. His areas of interest are macular disorders and the retinal imaging techniques. He has published over 400 articles. I don't think that figure is right, because by the time this is being said, he would have had another 50 added to that. He has won several national and international awards. That is what is there on the slide. But I would like to add one more thing. Years ago, there used to be a famous punchline of a famous TV ad which says, "Owner's pride and neighbor's envy." He surely has an encyclopedic scholarship. Of course, you are surely not the source of envy. We are proud of your achievements. Over to you, J. Chablani.
Thank you so much, sir. And it is really a great pleasure to be invited to this meeting. First thing, I just want to congratulate Dr. Muralidhar and Hemant Murthy, sir, for such a fantastic journey. And I think you all have really contributed a lot to the field of retina. And the second thing, I just want to confess to everybody, including the audience, that it is such an honor for me, particularly, we all get invited to many meetings. Particularly for this meeting, I would say that almost everybody in the speaker has been my teacher. I have learned so much from each of you from my days in KMC. It is such a big honor to speak in front of all of you. So I will just not waste more time, and I'll jump on to my talk today, which is choroidal imaging in 2021. Okay, are you able to see my slides?
Yes, we are able to see your slides.
Perfect. Okay, so let's see that what is coming up in choroidal imaging in 2021. These are my financial disclosure, and none of them are relevant to this presentation. So we all started talking about choroid long ago when we had ICG, as you can see in these angiographic pictures, and we could barely talk about the choroidal thickness by using B-scan. The things started changing when we had spectral OCT. We started looking deep into the OCT scans, and we just had a swept source OCT, which really made the word choroid very famous in the last 5 to 10 years. And we can see that by using the swept source OCT, we are able to see the choroidal structure so well that it is almost matching with histopathology, which we get on our scans. But yes, what is coming up next for us in 2021? So let's start with dye-based angiography, and which is now becoming one of the most common ways of looking at the peripheral choroid. And as I was talking about a few minutes ago, that now we have wide field ICG. And as you can see, this picture is from one of our paper recently we published in Progress, where we showed that how ICG can give us the information about the peripheral choroid, the vortices, and on the basis of this ICG, we can now talk about venous overload choroidopathy, which is now making the basis for pachychoroid spectrum. And as you can see the picture on the left, where we are showing the numerous intervortex venous anastomosis, which is primarily is the reason for the seeing thick choroidal vessels on our B scans passing at the macula. The picture on the right clearly shows that how the vortices are so much overflowed in a patient with CSC, and you can see here that the main vortex vein, which is present in the supratemporal quadrant, is the one which is most dilated. But to give you some more attention to the infranasal quadrant, where you can see that the vortex veins is barely seen. So with the help of wide field ICG, now we are talking about and trying to trace your pachy vessels all the way up to the vortices and talk about the decompression and the thick sclera concept for the pachychoroid. And there is still much more to learn about the peripheral choroid using these imaging technology. Let's talk about structural OCT. We were talking about automated choroidal segmentation way back in 2015, and we got these automated choroidal segmentation. Then we had a concept of choroidal vascularity index, and we have published a lot, and we all are using CVI in our daily practice, But what is coming up next for the CVI is something called as choroidal vascularity map. This is one of my recent publication where we are trying to show that as we are using retinal thickness map using ETDRS map, and now we have the opportunity to talk about using the same ETDRS map by calling it as a choroidal vascularity map. And you can see here that nice color-coded images. They are going to show us how the choroidal vascularity is distributed in these different sectors. So we took this work forward and we showed that by looking at the CVI map in the fellow eyes of these patients of CSCR, you will see that we did find correlation between the CVI and choroidal thickness, which we found altered in the CSCR compared to the fellow eyes and normal eyes. And we did see that there is an increasing CVI towards the center of the macula superiorly in CSCR eyes compared to the fellow eyes. So now it is time to really talk about the CVI map and really look at these focal diseases such as AMD and look at the CNV cases. If we are seeing any PNV where we can see the vascularity change in that particular sector, and you might be using PDT treating that sector alone without even doing an ICG. So we did look at the CVI map and try to correlate with the fluorescein angiography in patients with CSCR. As you can see in this publication where we are showing that the CVI maps are not showing any difference in the patient with CSCR, because probably the choroidal vascularity changed throughout and not just localized and correlating exactly with the leak area, as we saw in this patient, where you can see that the leakage is present in the supranasal to the fovea, but the CVI was increased all over in that zone, but did not correlate exactly with the leakage, which again proves the fact that the choroid could be thicker and the more area of the choroid could be abnormal rather than only that particular focal leak. And this again stands true for when we are offering a PDT in these patients. We are also looking into the various forms of choroidal vasculature, where you can see that we have tried to define various vascular patterns. And now we are looking into that which kind of vascular pattern could be making these patients more prone for having a CSCR. And in this paper, we did show that reticular pattern, which is the bottommost pattern in the picture on the left, the reticular pattern was more common in CSCRI compared to their fellow eyes, which had the herringbone pattern, which is the topmost pattern in the figure. So we went deeper into the choroid and we tried to look into the short posterior ciliary arteries. If you look at your B scan, which was taken in a swept source OCT, you can just look at the arrow on the leftmost image, which clearly shows that how these short posterior ciliary arteries are entering into the choroid. And we were interested in looking at this, and we published this paper recently in Scientific Report, where we could actually see these entry sites into the choroid. And now we are trying to evaluate that whether localizing these short posterior ciliary arteries could have some relevance, particularly in patients with CSR CNV or PCV or even myopic CNV. There could be some relationship that these short posterior ciliary arteries are localized in much more denser way in particular sector, which probably makes this patient prone for having CSR or CNV in that area. We are interested in looking at the 3D visualization of Heller vessel. There are multiple papers talking about the diameter of the Heller vessel using ENFAS, but we do understand that the choroidal vessels do not follow any particular pattern, but they are rather pretty much zigzag present. And that's why we wanted to use these volumetric scans, and we came up with this 3D visualization of the choroidal vessels. And now we are looking into their shape and change in curvature and the vascular diameter. And this is going to lead us to something more interesting and try to follow where exactly the CNV could be forming. I would not leave OCT angio, I would just say that like Dr. Mahesh Shanmugam showed, that choriocapillaries can be seen really well on OCT angio, but I still have really doubts that how reliable these indices are, which are coming up in many of the papers recently using OCT angio. We had to remember that even a subretinal fluid on a CSCR, which Dr. MPS was showing a paper recently, even the subretinal fluid in CSCR can also cause some shadowing, which can be considered as flow deficit. So we really have to work further on evaluating choriocapillaries on OCT angio. So what is up and coming in the clinic? And this is something which I'm doing, working on this here, as establishing a laser Doppler holography. And you are seeing that how beautifully we can see this choroidal vessels and the retinal vessel. And but just to give you a surprise, that these are non-invasive imaging modalities, and this powerful imaging platform is being used to evaluate the retinal and choroidal vessels. Just look at the picture on the right where you can see these choroidal vessels so beautifully. I will just take you further, and you can see that by using this LDH system, which we are working closely with our collaborators in Paris, where we are trying to see these retinal and choroidal vessels. And as you can see that you can easily differentiate them as the retinal arteries or retinal veins, and the choroidal arteries and choroidal veins. Just to take you deeper into the choroid, and this is a picture which was taken focusing on the choroidal vessels. As you can see, the LDH is the only imaging modality which can differentiate choroidal arteries from choroidal veins. We do have great ICG pictures, but we still don't know which are the choroidal arteries and which are the choroidal veins. And you can see that the resolution of this LDH is so good that you can actually focus and image each and every medium choroidal vessels really well, compared to the ICG, where the inner choroidal pictures get really fuzzy as the dye passes through more. So last but not the least, that we are now trying to use adaptive optics and ICG simultaneously. And you can see that how beautifully you can see these RP cells using the fluorescence imaging. But the picture on the right, you are able to actually now image the choriocapillaries microvasculature, which was not possible in any of the available imaging modalities. This is one of the tricky imaging modality which we are trying to work on. This is a paper from one of the centers from the US, where they have tried to inject ICG and take the images at the entry and exit and try to image the choriocapillaries, which is pretty much matching with what you expect to see in an electron microscopic picture of choriocapillaries. So there is definitely much more to do. So I would just end my talk by saying the woods are lovely and dark and deep, but I have promises to keep and miles to go before I sleep. Thank you so much for your attention, and I'll be happy to take any questions. Thank you.
Thank you so much, Dr. J, for that wonderful presentation, for taking us into exciting terrain. The choroid is really very hard to image, or I would say, I wouldn't say it is hard, it was hard to image, as it was sandwiched between the light absorbing RP and the optically opaque sclera, but not any longer. J. Chablani, you really have perfected the art of how to wow. Excellent talk.
Thank you so much, sir.
Are there
so
any
much
questions in the chat box, Purna, or do any
As
of the
of
members
now,
have any questions?
yes, as of now, question. Before that, I have excellent presentation as usual. So I have a question. So whenever you analyze these choroidal vascular changes and all, how often you take into account the axial length?
This is a very nice question, and axial length is definitely important, and I think that axial length and the choroid go hand to hand. So we definitely look into the axial length, and I would say not only just the axial length, rather I would really think about the curvature of the choroid as well. I did not speak about that particularly, but I think the curvature of the choroid and the way we measure axial length matters a lot when we are really looking into the things. So Dr. Rajni had a comment about bestrophinopathy patients. So it would be really interesting to see that how was the axial length and how important axial length plays a role when you are actually measuring the choroid. So whenever we really talk about the choroid, we have to talk about the axial length. Thank you for this great comment.
Yeah, Dr. J, from among the various newer modalities that you were describing, which among them do you think will leapfrog into the clinical domain in the foreseeable near future?
Yeah, so LDH is something which I'm particularly excited about, but setting up, because LDH is there is only one system which is right now in Paris, and we are going to have our first system or second in the world here in Pittsburgh. So, but I would say the AO-ICG is something which is still much closer, because there are multiple AO machines which are available, but again, it needs so much of technical change that I really doubt that we will be getting really close. But I would say may not be in the clinics, but towards the clinical research, yes, we are reaching there. In a year or so, we should have more publications using these techniques, at least for our clinical research papers.
Mahesh sir has a comment.
Dr. Jain,
yes, sir.
can I come in with a small comment?
Please.
So first time when we saw the ICG angiogram, I recall having a conversation with Dr. Mahesh and saying that, look, this looks like you're calling this a polyp and I'm showing this as a polyp. And we are having differences of opinion there. So it's like, blind men feeling the elephant and describing it as it was. And Dr. Mahesh said, you come and sit with me for 1 hour and I'll make the whole picture of the elephant come through. Your talk brought out the elephant very well.
Not yet.
Thank
Not
you.
Yet. Not yet.
Jay, wonderful talk.
Thank you, sir.
Like a lot of new things to learn.
Thank you, sir.
I just had a question like, how do you intend decongesting the choroid? What do you think is the direction to take in decongesting the choroid?
Yeah, we have discussed this many times before, but I really think that sclera is playing a role. I know that there is a paper saying that the anterior sclera is thickened, but somewhere in fact, the paper which we recently published in Progress is which talks about the overload vasculopathy. Eventually, this might really lead to decongesting the choroid, probably by making the scleral windows. The only unfortunate part is that there is such a limited series of opening the windows. I still don't know that how we are going to really successfully do that. Or are we going to make this as a surgical intervention for all our pachychoroid patients? But probably somewhere the antihypertensives, or if you really go deeper into this, that we really have showed that how a patient with keratocarcinous fistula also has these venous changes. So there is probably so much systemic things going on in a patient with thickened choroid that we are still unaware of. So still, we don't know.
Jay,
I think
ask you a question. Is there a role of pharmacotherapy in decongestion? Now you've just on the question of how do you decongest the choroid. Is the pharmacotherapy better than the surgical therapy? Because that would be a lot more trickier business.
Yeah, I mean, I like we were saying that, yeah, probably why does eplerenone works in some patients and why it does not work? Can we really think of using some antihyper treatment which can decongest it? So what do we do for our varicose vein patients? We don't know that. So can we come up with something like this, that patient has varicose vein and you have something similar in the eye? So can we really come up with decompressing somewhere like we are treating our varicose vein patients? So there is definitely so much to learn.
Yeah, I think we need to move forward, Hemant, because this webinar is more about congratulations and less about celebrations. No dinner from your end, so we need to move on
Thank
to
you
the
so
next
much.
speaker.
Thanks a lot.
And I request Dr. Praveen Murthy to please introduce Dr. A. Giridhar. Praveen, you are muted.
Dr. Giridhar does not need an introduction for this forum. He is a guru for all of us. He is a chief vitreoretinal surgeon and founder partner of the Giridhar Eye Institute. He is the past president of the VRSI and he has several publications, and his special interests include diabetic retinopathy and macular disorders. So we are waiting to listen to you. I think Dr. Giridhar needs to unmute himself and share his slides. Dr. Giridhar, are you there?
Yeah, I'm there. I'm just bringing my slides on. Yeah.
Giridhar, the women's tennis final must be over. I see the TV set in the background off.
Yeah, sir was showing how to multitask. So the tennis match was going on in the background, and sir was also asking questions.
Yeah, I'm a tennis enthusiast. So can you hear me?
Yeah.
Yeah, okay. Anyway, I'm a tennis enthusiast, and I was listening to the talks also. Anyhow, I'm glad to be here, and I would like to again officially congratulate my very, very old friend and acquaintance for more than 3 decades now, Dr. Murli, and his associate, Dr. Hemant, for reaching a very important milestone as far as their establishment and their journey in retina is concerned. And I wish them well and wish them many more years of active service to the community. My talk is actually a clinician's talk, unlike my good friend, Dr. Jai. He's a clinical researcher. I'm only a clinician. So I'm going to talk on ultra wide field retinal imaging, a little bit on our experience, and a little bit on what interests me as far as ultra wide field imaging is concerned. I have no financial interest in the equipments that are being presented here. So it's nearly 100 years now.
We are not able to see your slides.
We are not seeing your slides.
Okay.
Yeah, just share again.
Okay, I'm sorry. That's why I asked you. I'm sorry.
Giri, you have to stop share first, then open your presentation and then start sharing. Otherwise,
Yeah, one minute. What's happening? Yeah. Now, can you see it?
No.
Not yet.
What you have to do is minimize your Zoom.
Yeah, I'm doing it the same way I normally do it for the meetings. So
no, you're not able to see your screen.
Okay, 1 minute again.
Yeah.
I'm sorry, I'm wasting your time.
No problem. Yeah, yes. Now we are seeing it. Yeah. Okay.
You can see the slides now. Yeah.
Yes.
Now you can see it?
Yes. You can go on slideshow now. Yes.
Okay then, right. Okay.
Yes.
So So I'm just making a short presentation on ultra wide field retinal imaging, what has interested me in the last 1.5 years, and I'm just sharing some of our experiences. Actually, I have no financial interest in any of the equipments that are presented here. So it's nearly 100 years since Carl Zeiss first brought in retinal photography with the retinal camera, way back in 1926, when we had the first retinal photograph about 20 degrees of a total retina area. Now our standard imaging photography is about 50-degree field of view. And of late, there has been a lot of interest in wide field and ultra wide field retinal imaging because peripheral lesions are often left unexamined in routine retinal photography. So I'm just showing you the 3 modalities. We've been doing what we call as the routine standard retinal photography, where we can take multiple pictures of the posterior pole of the retina. And then a lot of interest came into what we call as a montage imaging, where multiple photographs are merged together to create what is known as a montage. It's very useful, but it takes a lot of time. It requires a very good expert photographer and a lot of effort also, and a good clear media also. So this is a patient with multiple photographs, one with the photograph with the Zeiss handle, the smart camera, then one with the montage with the Zeiss 450 plus camera, and the third is the full wide angle image, a 200-degree image, just to show you what is the difference between what we see in a montage and a wide field, ultra wide field image. So of late, there has been a lot of confusion as far as the definition of what is wide field and what is ultra wide field. And recently, the International Wide Field Imaging Study Group brought in a very concrete definitions based on anatomical landmarks in the retina. Therefore, they defined a mid-periphery as the area extending from the vascular arcades to the posterior edge of the vortex vein ampullae. And the peripheral or ultra-wide field is the area from the vortex vein ampullae beyond up to the pars plana, and pan-retinal is 360 degrees. So we are primarily going to talk about mainly the ultra-wide field image. So commercially available wide field imaging systems includes the Optos, which is developed by, belongs to Nikon. It's a non-contact method. We can screen with one picture about 200 degrees of the retina. The Heidelberg Spectralis has got two lenses which can be attached to the machine. One is the 55 degree to take a color photography, and the 102 degree to take a wide angle 102 degree fundus fluorescein angiography and endoscopy. We are going to work, be present on these two catalogs here. The Claris, of course, is 200 degrees non-contact. The Stauringi is not very popular because it's a contact lens. You need to put a local anesthetic, etc. And the Red Cram takes about 130 degrees of the retina. So the Optos actually produces a 200-degree image. It's a pseudo-color image using the SLO technology, both the red and the green laser. And using an elliptical mirror, we are able to screen about 200 degrees with one click of the retina. And this gives you good brightness, good contrast. And the most important thing is that you can adjust the contrast and the zoom to get better resolution, and the acquisition time is very short. So the various Optos devices, what we are going to talk about is the Daytona, which has got the color photography and the autofluorescence. Both are very useful. Coming to the clinical application, I'm going to focus only on diabetic retinopathy because we have been got interested in this during the last 1.5 years. Where, because of the COVID, I realized that this is a very useful gadget for detecting sight-threatening diabetic retinopathy. So this is the same picture which I showed you earlier, where we can see the differences between the various modalities of retinal photography. Conventional grading severity of diabetic retinopathy is the standard ETDRS 7-field photo. And this is, again, a very cumbersome technique, and none of us in our clinical practice are using this in gauging the severity of diabetic retinopathy. And that's where basically our deficiencies as far as detecting sight-threatening diabetic retinopathy in selected groups of eyes becomes very difficult. So if you superimpose the ETDRS grid onto the Optos picture, you can see that a large portion of the peripheral retina is unexamined. And if you see even in this particular photograph, you can see these peripheral hemorrhages, you can see these attenuated blood vessels showing signs of ischemia in the retinal periphery, which are often missed in routine clinical examination. What, however, interested me was the ability of the Optos photography to detect very subtle areas of neovascularization in patients with normal visual acuity and probably having sight-threatening diabetic retinopathy. This, I felt, is a very, very important step because the ability or the importance of any form of a screening program for diabetic retinopathy is to detect this vulnerable group of eyes which require early intervention. So small areas or subtle areas of neovascularization could be seen. You can see the neovascularization, the fluorescence here, and also these attenuated blood vessels or sclerosed blood vessels resulting in ischemia, which is obvious in the fundus fluorescein angiography using the Heidelberg Spectralis. You can also the peripheral retinal ischemia. You can see this particular patient here. He's got a sursonate here, not much changes, but then you can see this attenuated vessels here in the retinal periphery, and you can see this total capillary closure in the retinal periphery in both the eyes. In this background, therefore, I suggested a small study, and this is now under the final stages of publication, where to study the sensitivity and specificity of pseudo ultra-wide field imaging in comparison to wide field FFA in detecting retinal neovascularization in diabetic retinopathy. Therefore, we compared the pseudo color photographs with this gold standard, that the fundus fluorescein angiography, which is invasive, which cannot be used for mass detection of sight-threatening diabetic retinopathy. It requires a lot of trained nurses, a proper center with facilities to manage allergic reactions, etc. So the hypothesis was, is the pseudocolor ultrafilm imaging as accurate as standard FFA to robustly detect PDA in people with diabetes? So we therefore did a study from the last year, till the early part of this year. We took mainly two groups of eyes. One is severe that is basically patients in the outpatient department who were diagnosed as severe NPDR and early PDR. So these are the two groups of eyes probably where we need to really work on. So the index test was compared with the reference test, and we used the Optos Daytona and the Spectralis Heidelberg. So we used, the images were divided into 4 quadrants based on the recommendation of the International Wide Field Imaging Group. And you can see in this sample case here, how using the Optos, you can see these subtle areas of neovascularization, which are also demonstrated in fundus fluorescein angiography. Therefore, you had 2 independent mass investigators evaluating the Optos and the wide field fundus images directly from the machine. They had no access to the EMR data to avoid any bias in interpretation. And then basically it was correlated and discrepancies were settled by the principal investigator. I want to show you some more cases here. You can see the peripheral retinal ischemia in this particular case, and you can see these areas of neovascularization seen in fluorescein angiography beyond the central ETDRS7 field area. And this again, it shows you how useful the Optos is in detecting these small area neovascular networks. I also want to show you the asymmetrical presentations in this particular patient. It's purely nasal. You can see also in the photography here, it's purely nasal. And here also we can see here the nasal distribution, especially going more or less up to the equatorial region. And this again could be detected equally well, both with the Optos as compared to the fundus fluorescein angiogram. So we looked into the sensitivity and the specificity, all quadrants and each quadrant separately, but I just tell you that the sensitivity was about 92.5%, the specificity was about 81%. I do not want to go into the intricate details of this particular analysis. We also looked into each subgroup of patients, and both these are the 2 groups which is very important, and we found that the sensitivity was quite high, 82 and 90% in the subgroup analysis of patients. Therefore, in conclusion, therefore, we noticed that the pseudocolor ultra-wide field imaging has excellent sensitivity and reasonable specificity when compared to wide field, and it's an effective tool in detecting areas of neovascular, small areas of retinal neovascularization. And this probably is an important take-home message, especially in vulnerable population, when in large diabetes, hospitals, etc., probably a useful way, if it's possible, to invest in this particular equipment for screening and detection of sight-threatening diabetic retinopathy. So, and in fact, as a follow-up to that particular statement, I came across this article just recently published about 2 months ago from Japan, where they have used this particular technique in a diabetes center, where we use the ultra-wide field imaging, and they have transported the image using the cloud server to the nearby Nagoya University Eye Hospital, and they have evaluated the types of the incidence of diabetic retinopathy and also sight-threatening diabetic retinopathy. Therefore, just as I was thinking about this particular possibility, I found this particular case. Another thing which I would like to talk about, the interest in the peripheral retinal lesions in patients with diabetic retinopathy. There have been a series of articles published by Silva, and we are also working on this particular area. We really do not know even now whether these peripheral retinal lesions are very significant, and is it a warning sign for impending worsening of diabetic retinopathy. But this particular article and subsequent article by Silva has shown that probably peripheral retinal lesion is definitely could be a sine qua non for worsening of diabetic retinopathy in the near future. We are now looking into possibility of the peripheral retinal lesions being associated with comorbidities in diabetic retinopathy, and this is a small study that I'm doing now. So the ETDRS grid is superimposed on the Optos image to identify these peripheral zones and to mark the peripheral retinal lesions in each quadrant. Basically. There has been a recent study also from India, a multi-center study where they have looked into the peripheral retinal lesions, the incidence, and they say that the incidence is about 37% of eyes with diabetic retinopathy. Therefore, the incidence probably is not that high. And basically, I really do not know whether coexisting hypertension, stroke, nephropathy, etc., can act as precipitating factors for the presence of peripheral lesions in diabetic retinopathy. Of course, some of the other, applications in diabetic retinopathy, of course, is well known. That is, one is identifying areas for targeted pan-retinal laser photocoagulation, as you can see in this particular case, where you can give the targeted laser photocoagulation based on areas of ischemia, avoiding areas of good retinal perfusion. I also find it very useful in patients who have undergone complex PDR surgery prior to oil removal, just to check the complete retina and to make sure that the retina is very stable before oil removal, especially the inferior periphery of the retina, where the presence of slight fluid can result in recurrence after oil removal. So in summary, ultra-wide field imaging, I feel, has got an important role in screening, detection, and management of sight-threatening diabetic retinopathy. The limitation, of course, is the cost of the equipment. It can be utilized in settings with high volume of diabetes patients or diabetic retinopathy patients. I would like to acknowledge Nikon for providing this equipment for doing a clinical research work on diabetic retinopathy. Mr. Rakesh, our photographer, who's passionate about doing this particular job, and 3 of my fellows who have been instrumental in conducting some of our studies. Thank you all for your kind attention.
Thanks indeed, Dr. Giridhar, for expounding on the ultra-wide field imaging. You have always been a past master at such talks, really a practically oriented one. I have a question for you. Would you consider that the ultra-wide field imaging system as of now is indispensable to a retinal practice?
Well, my answer to that, Kumar, is that, once you get used to it, you wonder whether you can work without it, because it really opens up a lot of things which probably were, which was not in our armamentarium at all. So basically, definitely the answer to that question is yes. If you're having a high volume patients, especially with, there are many diseases that can be seen with ultra-wide field imaging. And ultra-wide field imaging probably in a busy retina OP becomes a part of retinal examination, because even in patients with myopia, etc., you're able to see the peripheral retinal lesions, etc., extremely well. But in diabetic retinopathy, I think it's got a very, very important role. That's what I have learned, and it's really part of my practice now. I do ultra-wide field imaging in every patient with diabetic retinopathy, because I will not miss. I'm quite sure that I may not miss, treatable diabetic retinopathy, because that's the take-home message.
Thank you, Giri. Dr. Prithvi, you may please come in. He wanted to make a comment.
Thank you. Thank you. Excellent talk. A couple of comments. The DRCR net is now running protocol AA. I think you had mentioned that. That will be comparing ultra wide field imaging to standard 7 field. I think that we may know the answer to that question before we get the paper, but it'll be interesting to see. And another area that I think will be of interest in future is the role of artificial intelligence and machine learning for auto detection. So we've deployed a network here at Stanford using the IDX system, which is the currently FDA approved AI-based detection of diabetic retinopathy as a screening tool. And again, the goal is not to diagnose degrees of retinopathy, but whether it's screenable retinopathy for referral or not. And it's not ultra wide field by any means, so we miss a lot of the periphery. But I think a lot of what may be coming could be software on top of the hardware that may allow for detection from a screening standpoint. But I think what we all want as retina specialists is that nth level diagnosis, not just, refer or don't refer, but, what degree and vision threatening. So it'll be interesting to see, and if you had any comments on that.
Can I make a comment, Kumar?
Yeah, please go ahead.
I've been using the Daytona since about 3 months now, and I find that actually you asked the question whether it is indispensable. I would say yes, in certain situations it is indispensable. For example, a patient in whom the pupil doesn't dilate beyond 2.5 millimeters and you're not able to see the posterior pole, let alone the periphery. You just put the patient on this machine and you can there it is for you the entire retina up to even 200 degrees. So I think that is one important, more than the wide field, it is the small pupil feature of the machine that is very, very attractive. And that is what makes it, sort of indispensable for certain situations where the pupil doesn't dilate at all. And another point is that it is a very good counseling tool. You can actually show the patient and convince the patient that he has a problem and he needs to undergo a treatment if he has a peripheral problem. Although the vision may be good, the peripheral problem that can be shown to the patient is something which comes in very handy to convince the patient to undergo their preventive treatment. I think these are the two things I just want to
question.
Yeah.
I have a question to all. I mean, Giridhar and Guru Prasad and Prithvi and Jay, who are using the wide field. Is it going to replace our dilated indirect ophthalmoscopy in our day-to-day practice?
I would say yes. Except that
so,
you don't
if you
have to.
It, would you avoid and not dilate and see, many of your patients?
Except that we can't indent. No, you can't do an indented examination. I think yes, it is equivalent to a dilated examination, with IDO.
Actually, I will just give you an example. I'll just give you an example. Actually, Mahesh, my colleague, my senior colleague Mahesh, he recently showed me a very interesting case. This was a lady post-COVID who had an exudative retinal detachment. Now, actually, he did the optos and he demonstrated a huge RP rip, which, probably in clinical examination you would have missed because it's not posterior, it's in the mid-equator. And it was a large RP rip. So it was actually a CSCR. It was an exudative detachment central serous choroidal retinopathy. We couldn't do an angiogram.
Wouldn't you have picked it up on indirect ophthalmoscopy?
Pardon?
Wouldn't you have picked it up on indirect ophthalmoscopy?
I mean, we could. I mean, we could have, but then you would have had to spend a lot of time. This one, within a second, you take the picture and you see it. You don't miss it. In indirect, you may, because it's a detached retina. So basically, there is a possibility that you may detach. But then the wide field autofluorescence, you just see that whole area. So it's not the wide field color photography. It was the wide field autofluorescence which diagnosed the rip. So,
Kumar, I think we'll have to. I think
we have inherited a delayed start already.
Yeah. No,
we have inherited a delayed start. So
Jai has a comment. Jai has a comment.
Yes, raise this hand. So I think that Jai, you can.
No, if you are getting late, it's okay. Just I wanted to say one thing, that we all really say wow about ultra field angiography, but at the same time, I would just raise concerns about the peripheral ischemia, which I get referred a lot of patients that we see peripheral ischemia on optos angiography. Unfortunately, we still don't know what is normal flow in our normative data. So we really cannot say that this is ischemia. So we just have to be careful whenever we look into the peripheral ischemia on optos angiography. So not every normal being has a very well perfused retina. So we just have to be careful about that. Thank you.
Thanks, Jay. in the interest of time, may I now request Dr. Purna Chandra to kindly introduce Dr. Guru Prasad and proceed with the next presentation.
Thank you, Kumar sir. And Guru Prasad sir, I have definitely does not require any introduction. So he's a well-known vitreoretinal surgeon, and his talks on trauma are quite famous. I still remember when I attended this first talk as a postgraduate, where he removed that non-vegetarian foreign bodies, including all vegetarian, non-vegetarian, all foreign bodies from the eye. And he heads the vitreoretinal service at MM Joshi Eye Hospital. And he has over 36 years of experience, and he has also been the past president of KOS. He has presented at various national and international forums, and he's a great teacher beyond whatever the credits what I mentioned. So we are great to have you here, sir. Over to you.
Thank you very much, Purna, for that kind introduction. So, first of all, I would like to congratulate Team RIK, headed by Dr. Murli, Hemant, and the entire team, for that matter, for their human service in the past 25 years, with a high standard of retinal care and now comprehensive care as well. So, thanks for this topic and involving me in the celebration of the 25 years of glorious practice. And thank you for this topic. I thought I will take the help of Dr. Srinivas Joshi, and I've added his name as a co-author for this talk. No financial disclosures. Intraoperative OCT stands for IOCT stands for intraoperative OCT, and also integrated OCT with the OPMI, that is operating microscope. And why we need OCT in the operating room is to know the macular micromorphology or the pathology in the middle of a vitrectomy. Basically, when you're doing a vitrectomy, you would like to know how the macula is on many occasions, and I'll show you some examples during my presentation. So just to show the older OCTs, the portable OCTs, which are handheld, some were externally mounted or microscope mounted systems, as you can see in these various pictures. One moment, I'll just minimize. Yeah. And the limitations were that the time required to bring the system into alignment was there. The surgery had to be paused and the instrument had to be brought into alignment. And then there was no real-time visualization. But today we have the various systems. So the three systems that are available today are the Rescan 700 from Zeiss, the Hackstreet IOCT, and the Enfocus Leica Provio 8. So this is the Lumira 700 with Rescan 700, which I am using. This is the Hackstreet IOCT, which I have no experience with, and Enfocus Leica Provio 8 is another very good system. So two higher end technologies are fused into one system, that is the Zeiss OPMI Lumira 700 and the Rescan 700, and that makes it a wonderful tool. We will see the examples of some of the surgeries that we have done with this system. So it's an integrated OCT scan controlled by Callisto Eye system. Sorry. Assistant system, live images seen on the external screen and in the microscope ocular over here. And the OCT images can be saved, can be actually photographed and saved, and we can switch between the saved image and the live image whenever we want in the middle of the surgery. And there is a feedback mechanism. The real-time OCT overlay, there is a simultaneous view of the surgical field and the intraoperative OCT B scan. And this is what I mean, the right ocular of the microscope. And we're able to view the OCT without the external monitor also, although we do use the external monitor in most of the cases. And we also have the Ingenuity with us, with which we have the Callisto and the Ingenuity, both monitors together for our comfort. And that enhances the ergonomics because of the feedback through the microscope oculars if you don't have the external monitors. So to start and stop scanning and to control the scan location, we can use the foot switch. And the IOCT is equipped with various scanning protocols, the 1-line, the 5-line, crosshair, cube scans, all are possible. Images can be captured and reviewed and even toggled between the previous images captured and the live image. And a vertical and horizontal OCT picture is mirrored onto the side and on the top. So this is what I mean, on the top and on the side, so that we can actually, the surgeon's right ocular has this image as well. So the applications, just briefly about the anti-segment applications, we have DMD repair, that is the Descemet's membrane detachment repair. We can use it in lamellar corneal surgery, which is very, very useful for the corneal surgeons for DALK, DSEC, and DMEC. For pediatric cataracts, for pre-existing PC dehiscence, very important, very useful test to do during the surgery because children do not cooperate preoperatively, and for goniosynculosis as well. Coming to the topic of today, posterior segment. So let us, before going into the posterior segment, let us see what we were doing, what was happening before the IOCT era. So, for example, this is a diabetic vitreous hemorrhage that has been operated 2 months ago, and post-vitrectomy, the vision has not been very satisfactory. And the OCT shows ERM with tractional diabetic macular edema. So it is very highly likely that a layer of hyaloid might have been left behind, or an ERM, which was very thin to visualize, might have been left behind, and that has proliferated, resulting in this picture. Similarly, we have had cases of RRD operated for, with vitrectomy, endolaser, and tamponade. And this is the 1 month follow-up, and you see that on a routine OCT, it shows a full thickness macular hole. So this is also very common, and this was happening before the IOCT era. So this is a case where a vitreous hemorrhage is being operated upon, and you can see that after clearing the media, there are some hard exudates here, which I wanted to evaluate with the OCT, and I found, I'm sorry about the OCT picture, it's not very clear, but what I'm trying to say is, if you do a routine IOCT at the end of every surgery, you can probably assess the macula better and prevent surprises like this. The reproliferation, which you had 2 months after this primary surgery, could probably be avoided, and a little amount of SRF that was left behind would not be any more surprising to you because it was already there at the time of surgery, and you can always wait and be rest assured that it is not a new SRF. This is something that I would like to share with you all. So PDR with vitreous hemorrhage was the indication for vitrectomy. I've done the vitrectomy, and I saw this hard exudate plaque and the epiretinal membrane here. I'm doing an ILM peeling using it as a handle to remove the ERM. And the hard exudate plaque was very firmly adherent to the ERM, and you can see that it is coming off along with the ERM through a retinal hole. So the intraretinal or probably subretinal hard exudate plaque came off. And this is where probably I feel that intraoperative OCT would have helped me to assess the patient on the table and probably plan how to do the ILM peeling and the ERM removal. So real-time monitoring of the vitreomacular traction is what I'm going to show here. So this patient has a vitreomacular traction and being operated upon by vitrectomy. PVD induction is being done, and after PVD induction, you can see that the traction has been removed, but there is an elevation of the macula. That doesn't really matter. So just to be on the safer side, the ILM is being peeled. You can see the shadow of the instruments here as the instrument is being passed over the retina. You can see the shadow passing across the scanned area. So that is probably a disadvantage. So this is just to show that we can actually monitor what is happening to the retinal surface with intraoperative OCT and confirm complete removal of the ILM. This is a macular hole. This I have shared from Dr. Srinivas. An extra large or ultra large, which I think Unni called it ultra large, I call it extra large. 1298 microns in diameter. ILM peeling is being done. The cabbage technique or the inverted peel or multi-layering technique is being done. And you can see at one point of time, there is a deeper pinch resulting in a hemorrhage. That is the point where a hemorrhage has occurred. I'm sorry if it is too dull. So the closure can be confirmed. You can see that the OCT is brought into place and the closure of the macular hole can be confirmed. And also, iatrogenic hole at this particular point can be ruled out. So this is one important indication where if there is any chance, by any chance there is a injury to the retina, we can rule out a retinal hole. So this is another case where the subretinal hemorrhage had led to the typical ochre-colored breakthrough hemorrhage, PVD being induced at routine surgery for clearing the vitreous cavity. And when we go to the area of interest, this is actually looking like a subhyaloid hemorrhage or maybe a sub-ILM hemorrhage. And with the help of IOCT and staining, both I would give equal credit to the staining as well. It was possible to actually find out the plane of hemorrhage. So the ILM is being peeled, and you can see that the ILM is coming off from the surface of the hemorrhage. And that is how we could actually locate or find out the plane of the hemorrhage. And then the hemorrhage was tackled appropriately. Another case of PDR with vitreous hemorrhage. Yeah, with TRD. So this is a case where vitroschisis could be identified, and a good demonstration of vitroschisis for the postgraduates. After clearing of all the fibrous tissue from the surface of the retina at the posterior pole and clearing the hemorrhage, we saw that, sorry, this is taking too long. Okay, on OCT, we could find that there was a remnant of epiretinal membrane. So probably this could have been, this would probably have, let us see just before the OCT again. So this looks fairly normal and, not without any problem. But when you put the OCT on, we can see the ERM there. And that is something that comes in very useful, as a very useful tool to remove the ERM, to identify the ERM and remove it. So, yeah. This is a case of an ILM transplant being done for a large macular hole. All I want to show you is that real-time monitoring of the procedure is possible. We can actually see where exactly and how exactly the ILM transplant is sitting. This is Helon being injected on the macular hole, and the stuffing of the ILM graft taken from elsewhere into the macular hole. And you can see in the real-time OCT how the graft is sitting in the macular hole. So there's a lot of controversy about non-tractional macular edema being treated with ILM peeling. So this is a case of fibrous tissue being there nasal to the disc and also causing some effect on the papillomacular bundle and probably the temporal retina. And I put the OCT on and find that there's a macular edema. There's no traction, but it's a non-tractional macular edema which was treated with ILM peeling. So detection of the condition, detection of the problem that the macula has at the end of the surgery is, I think, a very, very important feature of this IOCT, and the surgery can be planned accordingly. Coming to the last video, this is a case of a subfoveal PFCL. I'm sorry, the scan is not here. You can see the PFCL bubble just in this particular frame. And this is the 41 gauge cannula being inserted into the bleb and aspirated. So you can actually ensure complete removal of the PFCL, and you can ensure that there is no PFCL left behind. So just like that, similarly, we can remove the PFCL from other areas as well. But the most important place to remove from is the fovea. Yeah. So the pros and cons, microscope view affected but manageable. You could see that the grid or the crosshair comes in, which sort of obstructs the surgeon. We've got used to it now, but yeah, it does obstruct in the beginning. There is moderate resolution of the image, which is possible in real time. It's not really great. The OCT is not really great, and probably we should have more high resolution OCT in future. So surgical decision making is facilitated in macular surgery, and in thin scleras, sclerotomy sites can be imaged. For example, for a reproliferation causing repeated rebleeds into the vitreous cavity, probably you can image the sclerotomy sites for anterior hiloidal proliferation. And cons are instrument shadows can be very disturbing. 3D visualization is not yet available. Caliper function to measure is not yet available, and higher resolution scans are not at present available, but I think definitely desirable and may come in the future. So the future, probably very soon, not very far away, expanding indications of IOCT will be volume to area control for subretinal injections with, for example, air, gas, and TPA that we use for subretinal hemorrhage to prevent a burst of the retina. We can actually monitor the area also, not just the volume alone. An atraumatic BSS injection at the edges of the refractory macular holes and the macular folds that we sometimes come across, and delivery of viral vectors for gene therapy in retinal dystrophies, and subretinal, fetal retinal, or stem cell transplants for hitherto untreatable conditions. So these are probably the expanding indications that are going to come into the future. Thank you very much for the patient listening, and congratulations, RIK, once again, and thank you for the opportunity.
Thank you, Dr. Guru Prasad, for those excellent set of videos and eloquent and erudite as always. I have a question for you. Is there a learning curve for the novice surgeon when using an integrated system of the kind that you showed? Is it distracting to the beginner in any way to begin with?
Yeah, as I said, it does distract in the beginning, and it also is monocular. It's not binocular. The OCT image comes on in only the right ocular, and of course, when you're watching the screen, it's different. When you're watching the Ingenuity screen, it is different. But when you're not watching, when we are doing it with the analog camera, there is some disturbance that you do experience. More importantly, I think it's a learning curve for the technicians, because OCT, the image, the OCT, the crosshair that we have to put on overlay on the retinal tissue is something that the technician has to learn to actually focus it. So there's a lot of time lost in maybe a minute or so, but then once it is done, it really helps. So, and also it needs a little servicing from time to time, because probably there is some propensity to attract dust, and the technician keeps coming to clean the OCT, some optical part of the OCT, which makes it better every time there's a servicing done. So I think these are the pros and cons that I wanted to tell.
Just wanted to bring to the attention of all the viewers a comment made by Dr. Muralidhar here in the chat box that we are increasingly surrendering ourselves to the machines and creating more and more Frankenstein monsters. Any other comments on the talk by Dr. Guru Prasad?
I have used the intraoperative OCT for quite some years. And in fact, when I purchased it, I had a big expectation of how useful it would be. And unfortunately, I have personally been extremely disappointed with what I got. The Rescan 700 is a beautiful microscope, but the OCT leaves a lot to be desired. And it is, if you compare vis-a-vis staining, would you be able to use the OCT without the stain? No, you would not. So it removes the most important aspect. Yes, you can go back and check certain features during surgery, but these are few and far between. And the cost of the machine and the AMC that you need to pay offsets the entire benefits that you have and makes vitreoretinal surgery a loss-making enterprise for you. So I've been extremely disappointed. I hope they improve it further, and then it becomes a really useful tool. In fact, my anterior segment surgeons use it more than I do.
Thanks, Praveen, for that comment.
I just want to endorse what Praveen said, and as I said, the staining credit takes more credit than the IOCT. In one of my videos, I did say that. Yeah, one thing is to rule out holes. I think it is probably a good tool to rule out holes that could have been nitrogenically caused during an ILM peel. I think it does really help.
No, but having identified, having
ruled
in or ruled out
future
a hole.
indications. Yeah, the future indications are very attractive, like subretinal injections, the delivery of this thing. These are probably something which will come in very soon, sooner than we expect. And then something like this will be indispensable while delivering.
Very true, Praveen.
I think
I would now request Dr. Praveen, if there are no more talks, no more questions on this talk, to please invite the next speaker for the talk.
I would request Dr. Rupert Kanti Biswas, who's a senior VR surgeon. He's the first person to perform ROP surgeries, and he's the recipient of the Red Buckler Award, and he's serving as the Joint Secretary of the Ophthalmic Society of West Bengal. Sir, please go ahead and give your talk, and we are all waiting to listen to you.
Thank you, Dr. Praveen. And I would like to congratulate Murli sir and Hemant sir for this the big milestone. As a retinal surgeon, it's a big milestone for 25 years of serving it. And I would like to thank both of them for giving me the opportunity to be the part of this great occasion today. So I'll just share my screen now. So is it visible?
Yes.
Yes.
Yeah. So it was a very fantastic evening today. So we have learned a lot from today's talk. Now this is a multicolor imaging. I'm just going to talk about it. Is not a very new tool. It's a quite old tool, but we are trying to look into it in a very recently, so that to get more and more information. So I don't have any financial interest of any product I'm going to talk here. So the technique is relatively innovative technique. So what it is, it's actually a blue reflectance, then the green reflectance and the infrared reflectance. These are the three reflectance what we are using by using a confocal SLO, by which you get the three images separately, and then you composite these three images to create a multicolor images. You can more of a say that is a multi pseudo color images. So to create like these kind of things. So as you can understand from this basic technology, that it has a 3-layer of imaging which is being composed together. So the kind of a topographic evaluation of all the images and putting together. So just to show you the brief of it is this is the color fundus photography, how the normal flash photography causes, and you have a white light which is coming into the flash camera and going directly hitting up to the RPE and getting this red color hue, and anything in between which is coming here is giving a kind of a picture which is giving us a contrast, and then you get this image of normal color fundus photography. Vis-a-vis, when you come to a multicolor imaging, you have a blue, green, and infrared laser confocal SLO. Then here it is the blue. This is the blue area, which is actually the retroretinal interface, which is actually looking into it. Then you come to the green, which is the inner part of the retina, and the infrared, which goes towards the outer part of the retina and the RP there. So if you have a topography, so it is what I was talking about, it does not have any topographic evaluation in that way. So here you get all the 3 layers and then you compose it together. So this is a self explaining slide, which you have a blue reflectance here with of the more of a anterior surface. This is the middle layer of the retinal evaluation, and you have the infrared reflectance. All these 3 put together and you can have this. So there are people who already we are looking into it for quite long, for some time, and it has been proved that it has multicolor imaging has a major advantage over the standard color fundus photography. But for that, definitely you need a SLO machine for this. But it can be performed even through undilated pupil and is less affected by the media opacities. So I'll give you some example of that also over a period of time. So this is a normal standard color fundus photography, which I would say is a very good color fundus photography. If you can evaluate, you can see the detail of it. You can, I think, if you can make out of here, there is some amount of the epiretinal membrane, and here some amount of the ILM striae, and the retinal striae is also being located here. But look at here. if you look at the same time is a composite picture, you can much more delineate of the extent of the ERM and the changes occurring in the retina because of this epiretinal membrane. So even this layer changes and the retinal changes which is occurring here is much more prominent. So by this composite picture, the evaluation is much more better. This is recent publication by Dr. Naresh and their team. So this is a type 2 macular telangiectasia, and they have a very clear-cut evidence that this multicolor imaging can be a complementary imaging tool to color fundus, fluorescein angiography, and OCT, and it gives a much more information about it. So just to give an example, this is a type 2 here. So this is a color fundus, and if you can composite here, you can see much more information over this area. And this is another example of having a bullseye maculopathy, and if you hardly can make out any changes which is occurring, which you can see in a color fundus, standard color fundus photography, and if you can composite all these 3 of different layers, you can get into it of different areas. And the most important is that by having this color fundus photography, you have individual 3 layers also. So if you want to have a focus of interest of any particular layer, so that also can be achieved by this method as well. This is a picture where you have a severe form of asteroid, even color fundus, or even by indirect ophthalmoscopy also, the visualization was very, very difficult. And when you use this confocal technique, you see the changes here. So this is kind of a wow effect of what the imaging system has created. So by the confocal imaging, we can almost achieve, like we always know that in this kind of situation, we prefer to do an angiogram and see what changes is occurring. But yes, even without doing angiogram, also you can document it in a significant way for those areas of microaneurysms underlying, which is there in behind this asteroid. So there are different clinical applications also of you name any of the disease which has as a significant effect of this multicolor imaging, which gives you a much more information compared to a standard color fundus photography. So here is an example of a central serous retinopathy, where this multicolor imaging can be a good adjuvant tool to FFA or OCT as well, to localize the leaking area as well. This is when you see a color fundus photography, it looks like a cystoid macular edema, and then you do an OCT, you find there's an inner lamellar hole, and there's intraretinal cystic changes. So probably by doing this OCT, you can make out that it can be associated with optic disc pit, but by seeing this color fundus, it is hardly possible to find out any optic disc pit. But similar way, if you go to this, compared to this, your multicolor imaging, you can very well delineate this area of this optic disc pit. This blackish area compared to this more of a yellowish area. Here is it is the optic cupping, and here by the side of it is an optic cupping. Whether is it visible? If you can enlarge the screen and then can see. So how I explain these things, because you have a different layer of imaging. So because of that, and here this depth of optic pit and the depth of the optic cup is different. So because of that, the images what you are getting by different layer is also different. So by this way you can get the different color contrast. So this is a more deeper color, which is yellowish. This is a less deeper color, which is more blackish, and this neuroretinal rim, which is even more black. So by this way, you can delineate those areas very, very nicely. So this is also has reported to a journal. This is a nice case of having a diabetic retinopathy, but along with that, you have a myelinated nerve fiber, and within this myelinated nerve fiber, the optic nerve is almost disc is not being visualized. But once you do this multicolor imaging, you can almost visualize the optic disc margin very clearly, almost 360-degree areas. So this is also another example that again you are getting the advantage of different layer imaging. So by compositing these all images, you are again getting this nice optic disc image. This has also been reported. This is an example of a nice case. I always give an example of this case. I prefer to, by doing this color frontless photography, hardly you can make out, except there is a huge asymmetry between these two cupping of optic disc. Other than that, you can just make out that there is a vague RPE changes in the left eye. This is a gentleman. He is who is a renowned dental surgeon in Kolkata, and he after he was doing a procedure and he had a sudden exposure to the dental laser to his eyes, and then he was started seeing scotoma. So we were wondering whether there is there any changes in the other eye as well, but hardly we can make out with this color frontless photography. Then we did OCT also. We have seen he has a left eye which is actually, because of the chronic CSR, he had a RPE atrophy of that area. So he has, which we can make out here from the OCT as well. But the other eye, which was his precious eye, and this eye was having an intact OCT in the macular area as well. But he was very, very sure about his OCT, his symptoms. And then we did this multicolor imaging to note this. You can see this area of bleach of the complete area which has been exposed to this laser accidental laser exposure area. This is the left eye, which is already he has a scarring area in the foveal and the subfoveal, parafoveal areas. So this is again, and the RPE changes, RPE layer which is having a bleach area. I would like to thank my colleague, Dr. Rupak, Dr. Priyam, and Dr. Maharshi for collecting those nice cases and helping me to, putting it here. Thank you. Thank you so much. I think this is a tool which is being underutilized, and for each and every cases of retinal imaging, this can be an adjuvant tool to find or to delineate your pathology much better way. Thank you.
Thank you, Dr. Rupak. Increasingly, it's becoming evident that this session has been a rich man or a rich retina man session with all really expensive tools. Would there be just a couple of questions, please, because we are battling in the proverbial death overs now. We come to the last session. We can take one or two questions in this on this topic, if there are any. Otherwise, we will move on. Retina Institute always keeps the best for the last. And I now request Dr. Purna Chandra to do the honors in introducing our overseas speaker, Dr. Prithvi, please.
So thank you, Kumar sir.
Give me 1 second to share the screen. Just give me 1 second.
Okay,
I'll share the screen. I guess I got carried away by looking at all the nice pictures shown by Rupak Vishwas and wondering when I'm going to get this machine. Thank you.
Okay. So thank you, and it's an honor to introduce Dr. Prithvi Mrutyunjaya. Okay, he's an associate professor of ophthalmology and director of ocular oncology services at Bayer Science Institute at Stanford University, and he has multiple publications in the field of ocular oncology, imaging, and complex retina surgery. And he also holds a leadership position in American Academy of Ophthalmology and Retina Societies and the International Society of Ocular Oncology, and serves as a Retina Surgery Fellowship Director at Stanford. So welcome, Dr. Prithvi Mrutyunjaya. Over to you. You can start sharing your screen.
Thank you. Let me know if you can see my slides.
Yes, we can see your slide. You can just go to the slideshow mode. Yes,
Perfect.
Perfect.
Okay. Here are my disclosures. ಎಲ್ಲಿಗರಿಗೂ ನಮಸ್ಕಾರ. ಇದಕ್ಕೆ 25 ವರ್ಷಗಳ ಬೆಳ್ಳಿ ವರ್ಷಿ ಕೋಟಿಸವ ಆಚಾರ್ಯ ಸುತ್ತಿರುವ The Retina Institute of Karnataka ಇವರಿಗೆ ನನ್ನ ಹಾರ್ದಿಕ ಶುಭಾಶಯಗಳು. This is a very kind invitation and special one for me because the home that my mother grew up in and that I would spend many summers in is on the 5th Main Road in Chamrajpet, just down the street from the Retina Institute. And I had the opportunity to visit Dr. Hemant Murthy and Murli there a few years ago on my last trip to India. So wishing you all great success and God bless for all the service you have performed and the years to come. What I'll be talking today about the role of OCT in the diagnosis of ocular tumors. How do we diagnose these tumors and why do we use OCT in ocular oncology? And we'll give some examples on posterior segment tumors, specifically ones that may show up in your retina clinic. When you see a fundus lesion in a retina clinic, I think the real concern is this benign or is this malignant? Do you treat this or can you watch it? And if you miss a diagnosis, will I induce harm to the patient? So these are the concerns that always come in the midst of a busy clinic as to what we should do or not. In my oncology clinic, new patients typically get imaged extensively with fundus photography, ultra-wide field imaging, both color and autofluorescence. Fluorescein angiography is often used, and EDI OCT becomes something that is irreplaceable, but as well as standard ultrasound. So the key questions when you're imaging in a tumor clinic is where is the lesion? What layer of the eye are we talking about? Number two, is there a pattern that should be recognized? And three, are there secondary effects on the retina itself? And finally, can you use multimodal imaging to help confirm your diagnosis? So the answer to the last question is of course. So we're all familiar with taking a single lesion and looking at it in multiple aspects with imaging to learn as much as we can about these lesions to help make the most accurate diagnosis. And we use OCT in both anterior segment and posterior segment disease. And we'll focus on the importance of enhanced depth OCT for these tumors, because we know that the reference point that we're aware of initially when we first started using OCT was at the surface of the retina. But now that we move that checkpoint to the level of the RPE, we get a more deeper view of the choroid, and that is the EDI that we're all familiar with. In ocular tumor practice, we find that this is very helpful for several reasons. One, if we can designate the sclerochoroidal junction, it does allow us to get much more accurate diagnosis of thickness of these tumors, as well as the characteristics themselves. EDI OCT is helpful in tumors typically less than 2.5 millimeters in thickness. It does give us views of the choroidal patterns, and it does have much better axial resolution than ultrasound, 4 millimeters versus about 100, 4 microns versus 100 microns. And I think that that's really important in terms of the types of lesion that you choose to diagnose with OCT versus ultrasound. But the problem is the inconsistent imaging of that sclerochoroidal junction may limit its utility on measuring all patients and all lesions. We've been interested in the use of wide field swept source OCT for peripheral retinal disease, and we've published on this with the use of homemade systems that we've developed. Here we can see a sclerochoroidal lesion that can be seen on a single view with a ultra wide field OCT system. And now Optos has come out with a Silverstone swept source OCT that does give wide angled OCT options for patients. So I think that that may be something that we'll be hearing more about in terms of commercial options for OCT into the periphery. But the nice thing about some of the commercial systems currently available, including the Heidelberg system, is the ability to steer into the periphery, which we use all the time. So 4 questions when you have a tumor patient. So first is, where is the lesion and what layer is the lesion? So when trying to identify the primary pathology, we also have to kind of think of differentials as we go. So in the vitreous, we think about lymphoma or vitritis. In the retina, retinoblastoma, astrocytic lesions, combined hamartomas, and lymphoma. At the RPE, congenital hypertrophy lesions or CHRPE, and in the choroid, probably the largest area of concern, a nevus, a melanoma, metastatic lesions, and others. Some tumors are in or under the retina. So here's an example of an astrocytic hamartoma with the mulberry patch appearance, and we see this moth-eaten appearance of inner retinal hyperreflectivity and thickening, and also the autofluorescence correlate, which is quite white and bright, hyperautofluorescent. Here we can see a vascular lesion. This is a cavernous hemangioma with the classic cluster of grapes appearance. Normal retinal vasculature seen on angiography, except in the region of the lesion with the fluorescein cap. We can see the OCT that shows the cross-section of these multi-lobulated vascular events that are seen quite clearly. And here again, the angiography helps to show this as well. We've been using OCT in the operating room in the setting of treating children with retinoblastoma, and we've published on this extensively. And using the handheld OCT systems, we can identify non-clinically visible tumors, early relapse, vitreous seeds, and response to treatment. This is the Bioptogen handheld system that we're using. So this is a child with what we thought was unilateral retinoblastoma with no clinically evident mass. We do a standard screening protocol in the time of EUA, and we can see this interretinal thickening and hyperreflectivity, so detecting a clinically invisible mass, but very visible at OCT. We've been able to identify early tumor relapse. Here's a child who's been treated with a chorioretinal scar now in the macula. As we're watching the lesion, we can see that in some time there is a recurrence of the tumor with growth that was not as obvious on clinical examination, but clearly defined. And now we can follow that well on OCT. OCT in intraocular lymphoma is important because OCT helps to visualize various layers, all that can be sites of lymphoma infiltration and also secondary effects, but it also helps me to guide biopsy planning for these tumors. And especially if we can eye track, we can monitor these lesions over time to note response to treatment. Here's a 60-year-old female with blurry vision and gait instability. We can see this multifocal infiltration in the fundus. And if we look at where the lesion is located, it's clearly subretinal and not in the choroid, which makes the diagnosis of a lymphoma very high on the differential. You can learn a lot by not treating something. This is a case study that was reported that shows a patient with suspected lymphoma, that as the patient is followed over time because of diagnostic uncertainty, we can see some of the classic OCT signs start to manifest themselves in this patient, but most specifically at the level of the RPE and the sub-RPE layer. So we can see hyperreflective foci within the retina, within the vitreous. We can see sub-RPE deposits, undulation of the RPE, and as well as vitreous hyperreflectivity and sometimes thin epiretinal membranes. But remember, treatment is good. If you do identify this patient with abnormality and then treat them appropriately with chemotherapy, either intravitreal or systemic, we can see some normalization of these atypical features. And remember, lymphoma can also occur in the choroid, a different disease altogether, but we can see choroidal infiltration different from vitreoretinal lymphoma, where we see undulations at the level of the choroid and RPE, but no separation of RPE and Brooks, and clear choroidal thickening. So it's something to keep in mind as a differentiator. Here's another choroidal lesion, a 60-year-old female, asymptomatic, and has a papillary lesion, peripapillary lesion with what we call an inverted halo configuration. It's minimally elevated on ultrasound, but when we look at it on OCT, we can clearly see that there's a component of a choroidal lesion with minimal elevation and some compaction of the overlying choroidal capillaris. And this is a nevus, but I would call this a low suspicion nevus that can be still monitored. Similar age patient who's now visually symptomatic with a similar peripapillary lesion. No clinical elevation was clearly seen on ultrasound, but OCT now shows a more upward deflection of the choroid and RPE and overlying retina. There is some evidence of subretinal fluid, so this lesion now has a higher suspicion. Here's the patient referred for a macular tumor, not quite evident looking on photographs. On color fundus photography with SLR, we can see this reddish orange lesion with the characteristic angiographic findings on fluorescein and ICG. And on OCT, we can see this smooth domed elevation, non-compacted enlarged choroidal vessels with associated subretinal fluid that confirms the diagnosis of a choroidal hemangioma. So here's a lesion where OCT can be helpful. This is a 45-year-old woman with new fundus lesions seen on a routine examination, asymptomatic and sent in as an amelanotic nevus. Here we look at the imaging. What we see is the lesion is actually not at the level of the choroid. It is in the RPE. We can see overlying thinning of the neurosensory retina, thickening of the RPE. This is an example of an amelanotic Turpey lesion. So we can use multimodal imaging again to help confirm that there is absence of hyperautofluorescence and a hypoautofluorescent void that helps to confirm this. The next is there a pattern to recognize? So when we look at the OCT of a choroidal nevus, we're looking for what we call compaction of the choriocapillaris, which is something that we can see here on some of my histologic specimens, where you have normal choriocapillaris that has kind of an airy appearance with the large vessels. But in a melanoma, the melanoma starts from the deeper layers and pushes that choriocapillaris and compacts it. And that's the compaction that we see clinically. Here are some examples of choroidal nevi with compaction of the choriocapillaris and Haller and Sattler's layers, where we see this bright hyper-reflectance just underneath the RPE and in the inner choroid with some shadowing. Here's an example of a patient that has no clear compaction, but we see that hyperreflectivity. So that's a clear indication. We're all aware of the clinical manifestations of a choroidal melanoma, but sometimes these smaller lesions are harder to distinguish from a nevus. We know that when we OCT a choroidal melanoma, we expect a height or thickness greater than a nevus, the presence of subretinal fluid, and this dome-shaped appearance with, again, that compaction of the choriocapillaris. Here's another patient. Is this a melanoma? 45-year-old white male with acute vision loss in the right eye, is a healthy non-smoker with no family history of malignancy. So vision is 2150 with an exudative macular detachment. And if we look at the OCT, we see this choroidal infiltration, non-smooth, non-domed, but what we call a lumpy, bumpy configuration. As if we look at it more, we can see that it's actually quite elevated, more than one would expect just on the clinical photographs, and biopsy confirmed metastatic non-small cell lung cancer. And we know that the most common primary sites for these metastases are breast in women and men in lung, but it's the pattern that I want you to remember, which is this lumpy, bumpy pattern. The other reason OCT is helpful is once you've captured this image, it can help to decide response to targeted therapy. Here's just 3 weeks later after starting a targeted inhibitor, Tarceva, that allows for complete near eradication of that choroidal metastasis, and we can follow this nicely with OCT. So morphology aids in diagnosis. Here we see a choroidal melanoma. Here we see a choroidal metastasis. So that smooth domed versus lumpy bumpy appearance makes a very big difference. And finally, are there secondary effects on the retina? So OCT identifies surface alterations that we can see, intraretinal fluid collections, thickening, RPE changes, also subretinal and subretinal deposits and subretinal fluid. So here we can see various examples of fluid that may represent themselves during these cases. And finally, can multimodal imaging help to confirm a diagnosis? So a couple of examples. This is a 78-year-old male with pigmented lesion that was sent in as a peripheral melanoma. So concerning just by looking at the photograph for sure. We can see it out here in the periphery. Fundus autofluorescence shows kind of a mixed pattern with some hypoautofluorescence predominantly along the periphery. We can see this dome-shaped elevation that doesn't look solid anymore. We see the low internal reflectivity that's seen in melanoma, but this is very low internal reflectivity. Fluorescein angiography shows some pooling, which makes me less confident that this is a melanoma. And now we move to peripheral OCT imaging with the Heidelberg system, where we can steer into the periphery. And now we see that this is no longer a choroidal lesion, but in fact a sub-RPE lesion, which is a hemorrhagic pigment epithelial detachment, which is also known as an ectopic disciform or PEHCR lesion. And the nice thing is, unlike a cancer which grows, these, as you follow them, get smaller. And we can see as they do, we can see the multi-lobular nature of the PED with the buttress of subretinal fluid. Interestingly, Dry Shroff has recently published on this and added this to the spectrum of pachychoroids with some of the authors, including Jay Chabani and Cyrus Shroff, who are on that paper. Finally, an example of an amelanotic lesion that we published that looks suspicious for possibly a small metastatic lesion or a granuloma. We see on fundus autofluorescence not much of an image that's seen. Here we can see minimal elevation on ultrasound, but a characteristic finding of what we call a focal scleral nodule, where the lesion is not in the retina, not in the RPE, not in the choroid, but it's actually a scleral lesion that is pushing forward and compacting the overlying choroid. And this has now been identified and reported as a finding of a amelanotic lesion, small, round, discrete, that is unlikely to be a choroidal granuloma. So the tips to tell you is to identify which layer the tumor is located in, look for key patterns. Lumpy, bumpy equals choroidal metastasis, and compaction of the choriocapillaris more characteristic than a nevus or a melanoma, and look for those surface features that may help to prove or disprove or raise the suspicion, such as subretinal fluid or the presence of drusen. Think about, again, what layer the pathology may be located as you take your initial looks in the clinic, because that will make a big difference as to your final diagnosis. Thank you very much for this kind opportunity.
Thank you, Dr. Prithvi Mrityunjaya, for an excellent presentation with lovely pictures and cases. May I request Mahesh to please come in if he has any comments on this topic.
Thanks, Kumar, and wonderful lecture as usual from Dr. Prithvi. He pretty much covered everything and very elaborately and beautifully. I don't think I have any other comments on this.
I would like to add just one comment, if I could. I'm going to reshare my screen because it brought up a point that was added, alluded to before. So somebody asked, does wide field imaging ever take the place of a clinical examination? So here in the United States, and I don't know if it's the same in India, optometrists are now offering Optos wide field imaging as a alternative to dilation, because no one likes eye drops and no one wants drops put in. So for a cash price, usually between $40 and $50, there's a waiver that's signed and patients decline dilating drops, then patients will get an Optos image. So we see a lot of patients with lesions that are found just on Optos, but not on a dilated fundus exam. So here's an example of a 54-year-old pediatrician who visited his local eye care professional for what ended up being a paid undilated fundus examination. So I think you would agree things look pretty good on these photographs, but the scary thing is that when his friend, who's a pediatric ophthalmologist, gave him his next dilated eye exam, you can see that he actually was housing a far peripheral melanoma. So we can be easily fooled that we can see everything, but nothing beats a good dilated eye exam.
Yeah, which begs the question, how, while leveraging the advantages of the newer gadgets, how do we not lose our keen sense of clinical examination? Or is it that the keen sense of clinical examination is no longer required because these equipments hand over everything to you on a platter? This is a moot question I have for you.
Yeah, moot answer. I think that imaging is so helpful and so powerful, and I think sometimes we can get lulled into a sense of ease, and especially in busy clinics and flow, we trust our imaging so much. But I think first principles are always important. And as someone who teaches fellows, like many of us do, it's really important to at least impress upon them in their training, and hopefully they don't forget that when they leave training.
That's right.
Yeah, so technology should be used to amplify and not nullify the basic clinical instincts and to brighten and not blighten, as they say. Yeah.
Shallow detachments also can be easily missed on the obtuse. It's not a 3D. So shallow detachments that can easily be missed.
Thanks, Prithvi. It is comforting to know that dilated fundus examination is still going to be around for some more years. Before we,
So at least 25 more years of business for the Retina Institute of Karnataka. So don't worry.
Thank you. Okay.
If there are no other comments on the last talk, I would like to thank Dr. Praveen Murthy and Dr. Purnachandra, and once again congratulate RIK, and leave you with this thought that tomorrow, same place, same time, we'll be meeting again for another round of discussions. It will be mostly on surgical retina. Would Hemant have something to say as we end?
Yeah, thank you, Kumar. I think it's always wonderful to have you chair a session. Thank you, Praveen and Purna, for conducting this session so well. I know it's been very nice. We have had excellent talks. Thanks to Jai. Jai had to leave for some surgery. Then we had Dr. Giri. Thank you very much, Dr. Guru, Dr. Rupak, and ultimately, last but not the least, Dr. Prithvi. I thank you very much. I know we always meet at some meetings, and I always feel that we should interact more on such occasions. Thank you very much. Thank you, everyone, for a wonderful exchange of ideas. Thank you very much.
Thanks.
Thank
you.
Thank you.
Thank you, sir.
Thank you.
Good night.
Thanks to everyone, and we will meet at the same time, 6 p.m. tomorrow for another round of more interaction. Thank you very much, and good night to everyone. Thanks to Sai Numerotech for the wonderful technical help in conducting this session. Thank you so much.
Thank you.
Good night,
Thank
everyone.
you. Good night.
Thank you all. Thanks.